kementerian.go.id/fitur-RME. Sekarang habis berobat, datanya bisa muncul di Satu Sehat Mobile. Kamu hanya perlu install dan update aplikasimu ke versi terbaru. Satu Sehat Mobile tersedia di App Store dan Play Store. Kemudian verifikasi profil Satu Sehat di fasilitas kesehatan yang terintegrasi dengan Satu Sehat. Ini dia caranya. Siapkan KTP dan data kependudukan. Petugas akan cek kesesuaian data KTP dengan profil Satu Sehat Mobile kamu. Lalu, profil berhasil diverifikasi. Ada tanda centang birunya. Setelah profil bisa mengakses data. Jaga dengan keamanan berlapis. OTP yes, KYC yes, PIN yes. Punya pertanyaan terkait resume medis atau terkendala saat verifikasi profil? Jangan khawatir, kamu dapat mengunjungi link
Good afternoon, distinguished guests, ladies and gentlemen, and we welcome you to the Indonesia Health Partners Meeting 2025. As we will begin the event shortly, we kindly request that you proceed to your seats as we may begin in just a moment. Thank you for your cooperation and attention. Good afternoon, ladies and gentlemen, and once again, we welcome you to the Indonesia Health Partners Meeting 2025. And we invite you to please kindly fill in the seats that is available in the room. Once again, please do kindly fill in the seats and please do fill in the front row tables first. Selamat siang Bapak dan Ibu hadirin. Kami persilakan untuk bisa mengisi tempat duduk yang telah tersedia dan kami mohon kerjasamanya Bapak dan Ibu untuk bisa mengisi tempat duduk ataupun meja yang berada di barisan terdepan terlebih dahulu. Sekali lagi kami ucapkan selamat datang di Indonesia Health Partners Meeting 2025. Ladies and gentlemen, we welcome you to Indonesia Health Partners Meeting 2025. And we invite you to please enter the room and kindly take a seat, for we will begin the agenda in just a moment. Once again, ladies and gentlemen, for those of you who have not yet entered the room, we invite you to please do so, and please kindly take a seat, for we will begin the event in just a moment. Thank you.
Cek.
Ladies and gentlemen, once again we welcome you to the third Indonesia Health Partners Meeting 2025. The event will just be about to begin momentarily. Once again, we invite you to please kindly take a seat as we are about to begin the third Indonesia Health Partners Meeting 2025 side event. Ladies and gentlemen, welcome to the third Indonesia Health Partners Meeting 2025. Can I have a big round of applause for our event today? Distinguished guests, ladies and gentlemen, allow me to introduce myself. My name is Sarah Wayne, and I will be your master of ceremony for today. It is an honor and pleasure for me to be part of this wonderful event, the Indonesia Health Partners Meeting. The Indonesia Health Partners Meeting, or IHPM, is an annual forum organized by the Ministry of Health of the Republic of Indonesia in close collaboration with development partners. And this forum serves as a platform to strengthen collaboration and shared commitment in accelerating health transformation here in Indonesia. And distinguished guests, ladies and gentlemen, the third Indonesia Health Partners Meeting 2025, in conjunction with the 61st National Health Day, carrying the theme Harmony for Indonesia Health Transformation Acceleration. And we are very honored to welcome you and to have you, our distinguished guests, the team leaders of our development partners. So we thank you very much, and please do accept our gratitude for our invitation, and of course for attending this event. Can I have a big round of applause for each and every one of you here, ladies and gentlemen? Thank you. Distinguished guests, ladies and gentlemen, our program today consists of two main segments, the side event and of course the main event. And during this afternoon side event, we will be exploring flagship health transformation initiatives which offer opportunities for collaboration with development partners. And later, at the main event, we will enjoy dinner and celebrate a series of showcase of our collaboration and, of course, our best practices together. And at this wonderful afternoon, we are very honored, ladies and gentlemen, to have our Vice Minister to open the session. So without further ado, ladies and gentlemen, please welcome Professor Dante Saxono Harbuono to deliver his opening remarks.
Your Excellency, distinguished guest partners, ladies and gentlemen, Good afternoon. Have a nice day today. It's a honor to welcome you in the third Indonesian Health Partner Meeting. I would like to say that the health of our people is the health of the nation. Without the future maybe not exist. We are always reminded that health is essential in investing in national development. However, the true test of this principle lies is our ability to respond to the challenges that shape our health landscape. Over the past years, we have faced various situations such as the rising case COVID-19 in Asia, and also we have the food poisoning incident linked the free nutritional meal program or MBG, and we also have the hydrometeorological disaster in Sumatra now. All the which have directly revealed how capable our health system is in responding to this challenge. Ladies and gentlemen, each year we celebrate National Health Day, a moment that invites us not only celebrate but also to reflect on our effort in providing the health of all and ensuring our future remains secure. And in conjunction with the 91st National Health Day, we continue to pursue our goal of building a health system that is resilient, inclusive, and able to adapt the future challenges. This year's Harmony for Indonesian Health Transformation Acceleration is an important theme that highlights the need for strong partnership and shared responsibility. We confirm today at pivotal moment. Today, the Indonesian Health Partner Meeting provides us with a platform to come together and invited all development partners, national stakeholders, and broader health ecosystem to reaffirm our collective commitment to supporting the country's health transforming agenda. Ladies and gentlemen, in addition in our national challenge, global health priorities are being reshaped by shifting geopolitical landscape, involving development financing and the growing engagement of the private sectors. For Indonesia, as a middle-income country, this dynamic presents both opportunity and responsibilities. First, we recognize the need to strengthen our domestic capacity and diversity our financing problem. And second, at the same time, we must also have a continue improving efficiency across our health system through strengthening procurement processes and more strategic purchasing. To maximum value every investment is also important. We are committed to expanding the use of health technology assessment, ensuring that essential service and products are prioritized based on proven health impact. Lastly, we must enhance accountability and ensure that our reform effort remain aligned with the global commitment. Ladies and gentlemen, Indonesia remains fully committed to fostering a collaborative environment where innovative thrive, partnership deepen, and no one left behind. Within this context, we continue to advance the core pillar that supporting strong health system, primary and secondary care, health talent development, health resiliency, financing transformation, and digital health. While the Ministry of Health stand the front of delivering health services, the contribution of our development partner remain truly indispensable. Furthermore, your technical expertise, financial support, and long-standing collaboration have been instrumental in helping Indonesia advance in its health system reform and strengthen the well-being of our people. Let us continue advance in the health system capable and of protecting our people and contributing to global health resiliency. Thank you very much.
Thank you very much, Professor Dante, for your inspiring opening remarks. And next, ladies and gentlemen, for our next agenda, we will hear overviews of the programs which will be presented and discussed during this side event. And to moderate this session is the Director for Global Health Policy, Strategy, and Governance. But before I invite onto the stage Bapak Harditya Suryawanto, allow me to briefly introduce him. Bapak Harditya Suryawanto currently serves as the head of the Center for Global Health Strategy and Governance at the Ministry of Health of the Republic of Indonesia. He has served in several overseas postings, including at the Indonesian missions in Vienna, Washington, D.C., and Canberra. His background includes extensive work in international security, disarmament, and global health diplomacy, as well as experience negotiating various international agreements. Bapak Harditya holds a Master of Laws from Columbia University Law School and a Bachelor of Law from Universitas Indonesia. So distinguished guests, ladies and gentlemen, it is my pleasure to invite onto the stage Bapak Harditya Suryawanto. Please give a round of applause.
Terima kasih MC. Thank you very much. MC, Pak Wamen, Pak Asnawi, ladies and gentlemen. Before we proceed, allow me to extend our condolences and also sympathy to our brother and sister in Sumatra as of victims in recent natural diseases at the region. So our deepest sympathy for them and condolences. So our thought as well and prayers also for the victims, for the responders, and the family of the victims. So colleagues, ladies and gentlemen, I want to start by saying one of the famous proverb that if you want to go fast, you travel alone. So, but if you want to go far, you travel together. I think this quote has been mentioned several times, but I think this quote is quite relevant to our discussion today, throughout this day, especially this event as we, Indonesia, we've been, conducting what we call the journey for health transformation system. So the journey started in 2021. So throughout these 4 or 5 years, we gather almost 1.2 billion US dollars that has been disbursed across 6 pillars of our health transformation programs. So we will see the progress, but not this event, but later this evening, we will see the progress, and also some of our DG, Director Generals and Directors will convey and will deliver part of our accountability to our international partners. But today's event is, this afternoon event is quite important, where we will hear more on what we call the proposal of our programs from our speakers within the Ministry of Health. I noticed that for next year's program, 1.1 billion US dollar is needed as a catalytic investment to invest our priority programs across these 6 transformation pillars. So our 6 transformation pillars is quite bold, and then part of this health transformation system is financing, but the transformation is more than the financing. It needs advanced digital health that support each other. So if you learn about six transformation pillars, it's not working in silo, but it's work like there's a link between one pillars to another pillars. So as I mentioned earlier, like this for at least for next year, we need almost 1.1 billion Catholic investment. I don't have any details on that one, but at least for today's event, we will hear more from our speakers in detail about those programs. So on my notes, we have almost 25 programs that we collected, at least until today. We will hear more in detail, but let me start at least for this afternoon. I will start the first session by inviting Professor Asnawi Abdullah as our speaker. Professor Asnawi Abdullah is head of National Health Policy within the Ministry of Health of Indonesia. So without further ado, please let me invite Professor Asnawi Abdullah for his presentation. Please, Pak. Welcome, Pak Asnawi. Before you start your presentation, I know that your role is quite important within the Ministry of Health, Pak, because behind the policy, behind every recommendation, we start with research that that coherent and comprehensive enough to be like a single policy and recommendation. So I know that you and your team are preparing a numbers of programs, and also that that you will convey to our partners or potential donors. So, Pak, let me give you the floors. We have almost 30 minutes for your session, Pak. But if you can have like your presentation in 5 to 10 minutes, so then we can continue with question and answer and discussion. Please, Pak Asnawi.
Okay, thank you Pak Adit. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, good afternoon, distinguished guests, honorable participants, ladies and gentlemen. In this relatively short time, I present three proposal. Can you show the next slide?
Can anyone share the slide, please?
Okay. One of responsibility of health policy agency is to develop policy to provide the recommendation health policy to the Ministry of Health, but we want the policy based on the evidence. Therefore, we propose three topics related with evidence-based policy. The following slide. Yeah, this is in the first topic related with cardiac and stroke catheterization services, but we want to focus on equity issue. We propose the title, The Golden Hours Equity Initiative. A strategic policy review how to strengthen equity access to timely cardiac and stroke catheterization services across Indonesia. The second topic related with the burden of disease. We propose a title of our project, How to Strengthen Evidence-Based Policy Through Development, Indonesia Disease Burden. The last topic we proposed related with micronutrition supplementation as a strategy to reduce the maternal and child health mortality. Let me start with the first topic related with Golden Hours Equity Initiative. Let me read the summary in case I don't have detailed time to explain in the following slide. As we know, the cardiovascular disease, particularly acute myocardial infarction, heart attack, and ischemic stroke, are among the leading cause of death globally, as well as in Indonesia. Timely intervention through cardiac and neurovascular catheterization within the golden hours significantly reduce mortality and long-term disability. However, the problem is access to catheterization or cath lab in Indonesia remain highly inequitable, with the services concentrated in major urban centers, leaving rural and underserved population at severe disadvantages. Therefore, this proposal we propose. The following slide, just to show you, in last 2 decades, the pattern, the burden of disease is changed from communicable disease to non-communicable disease. The following slide are also to show the interesting figure. If you see this, all other ASEAN countries, cardiovascular disease is declining in this decade, but not the case for Indonesia. This make us little bit try to understand why other country, all other ASEAN countries show declining, but not the case for Indonesia. The following slide. Therefore, one assumption is related with access to cath lab, particularly access in golden hour. The next slide. However, in reality, many areas across Indonesia do not have access to cath lab services. To overcome this issue, next slide, Indonesia government is committed to expand access, cath lab access across Indonesia. But the problem, as you see in this figure, at the moment, Indonesia only 25 of district and city equipped by cath lab services. So then, why this study is important, there are several critical policy questions need to be answered. The first question related with what should we do and what are the best strategy to provide cath lab for remaining 75% of region. Where should a new cath lab should be located to maximize impact and ensure equitable access? Are our emergency referral pathway we have at the moment is already truly effective implemented? Are we delivering care that is high quality, safe, and most cost-effective way? What is the actual patient experience? All these answers should all these questions should be answered through the project. So then we can provide cat lab services more equitable for all people of Indonesia, regardless where they live, what social economic status they are. This project, next slide, will generate actionable evidence through implementation research using different methods. Probably, next slide. So by doing this research, we can produce a couple outputs. The first related with prioritization cat lab provision mapping. So then we also can strengthen our referral system, and then related with improving the quality and outcome assessment. That's the first topic. The second topic related with Indonesia burden disease. This project aims to strengthen evidence-based health policy through development of Indonesia disease burden, aim to shift the system toward genuinely data-driven decision making. The initiative focused on establishing a reliable national burden of disease that can guide more effective and forward-looking health policy. The next slide. So probably most of you wondering why we need Indonesia health burden of disease. We already have global burden disease, but why we also need Indonesia burden disease? Why Indonesia burden disease is so important for us? When we see to the way we make the planning at the moment, often driven by public opinion pressure, social media pressure, for example. And we quite often make the planning only focus on short-term period or administrative target. So the paradigm shift from data, we propose the paradigm shift data-driven policy is so important. For accurate identifying current need, and we also forecasting the future demand and developing sustainable strategy. In other way, I would like to say, for example, we know the burden of disease is changing due to demographic transition, epidemiology transition. We can predict what kind of services we need in next 10 or 20 years. So we hope by having global burden of disease, Indonesia version global burden of disease, then we can make the policy, long-term policy for the next 10, 20 years. We want to move the policy focus on relatively short-term period. The following slide. So this is the key benefit and strategic value by having Indonesian version burden of disease. The first related, we can integrate it, the Indonesia burden disease data to national and sub-national level. And then we also can support the evidence-based resources allocation. And the third one, a reliable foundation for forecasting future need. This is the most important aspect for forecasting the future need for Indonesia. The project covers three main activities. The first project related with leverage health system information, data integration and interoperability, strengthen global burden disease estimation, management and governance capacity building, and the most important also data to policy. The third project we propose related with the potential impact of the multi-micronutrient supplementation policy in order to reduce maternal and child mortality rate in Indonesia in the future. In short summary, multi-micronutrient supplementation introduced basically to replace FA tablet in order to minimize maternal complication and improve the outcome of pregnancy, which potentially reduce maternal and child mortality rate in the future. Currently, MMS program is being piloting across 15 provinces, all districts in 12 provinces, each district in 3 provinces. A key benefit of this initiative is to generate evidence-based policy recommendation that will facilitate the effective, timely, and targeted supplementation of MMS. Next slide, a couple points I would like to highlight here. For many years, the program providing iron tablet to pregnant women has been implemented as an effort to reduce anemia and improve maternal and infant health. However, the program has not yet fully achieved the expected outcome. Thus, we introduced MMS to replace iron is being piloting across 15 provinces. Although this project still in piloting, we want to learn from the pilot to provide a policy recommendation that ensure MMS is implemented effectively, on time, and targeted correctly, so the expected outcome can be maximized. So this is a couple project output. The following slides and a number of project activities. Probably this slide is enough for the presentation, and I give time for discussion, any question, or maybe we can explore a couple issues related with this project. Terima kasih, Pak Adit.
Thank you, Pak Asnawi. Give a warm applause, please, to Pak Asnawi. It's quite comprehensive from those 3 programs. I noticed that, as you mentioned earlier, Pak Asnawi, about your role as a policy center within MOH, it is our role and main duty to provide, evidence-based policy that include with a comprehensive analysis. So the policy recommendation that you and your team produce will be based on scientific and evidence-based. So I think I just also noticed. I also noticed from one of your slide that at least for cardiovascular diseases and also the maternal micronutrition program, that this is not, if I can say, this is not something new. This is like one of the our efforts to strengthen the ongoing program, especially in cardiovascular disease and also the micronutrition that will support our goals to eliminate stunting, Pak Asnawi, in our health priority, and also about the burden of disease. I know that it's been years since we need to also to revitalize or also to develop our own burden of disease. So with that kind of data, that I think we can easily analyze where we are right now in terms of burden of disease. This is also important. You also mentioned in your presentation about how you will utilize the ongoing, one of our ongoing program on Satu Sehat Pak Asnawi. So it shows to the audience that while we're doing this research, we want to also take leverage of our ongoing program, this this Satu Sehat, where we collected all the data information from all Indonesian population to identify, to assist us in identifying the burden of disease of our population, which also lead us to not only the curative, but also the preventive side, Pak Asnawi. Thank you very much, Pak Asnawi. I will open the floor. We have almost 15 minutes before our next presentation. We have quite space for question and answer for our discussion. So I will open the discussion, and let me start by 3 questions first from the floor or from the audience to these proposals, at least for these 3 proposals from Pak Asnawi. Anyone? Yeah, I have one right in the middle. Please, microphone. Please identify your name, Bu, and also your affiliation.
Okay, of course.
Yeah. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Pak Prof. Dante, Bapak Ibu dari Kementerian Kesehatan, Pak Asnawi. Thanks for the opportunity. My name is Reswita. I'm the Director of Communication and Government Affairs for GSK. GSK Indonesia is a global biopharmaceutical company. So I think, first of all, thank you, Pak Asnawi. Very comprehensive 3 pillars program priorities, and thank you for sharing the progress to us. I do have 2 questions, but if I can focus, it will be more towards the second pillar. I think when you mention about the burden of disease, it's really very good program and very comprehensive. For example, recently GSK, we work with academicians for the analysis of BPJS data from last 5 years in regards to what are the trend of the disease in selected provinces. And the data is really amazing. My question to you is that sometimes when we talk about burden of disease, we focus on the disease and the treatment needed. But if we learn from other market, they also focus on preventive actions before the disease even start. It means that currently, for example, we have comprehensive pediatric vaccinations, but then what will be your directions and what will be your thoughts in regard transforming that big data in BPJS on preventive measurement for vulnerable groups like elderly populations or those with comorbid like cardiac, diabetes, and hypertension. So keen to understand if it will be part of the national program for that transforming big data into decision-making process of preventive measurement for these vulnerable populations. Second, I believe that this kind of action cannot be done solely by the government. Will there any opportunity for private sector to chip in or collaborate under public-private agreement or collaboration with your team or other respective department in Ministry of Health to make it happen? So I think that's a 2 questions that I have in mind. Hope that's clear. But once again, thank you, Pak, for the very comprehensive program that you and your team have conduct for these 3 pillars. Thanks a lot.
Thank you. Another question? Please, also, Pak, please identify yourself, Pak, and your affiliation.
Thank you. I'm Dr. Sarabjit Chadda. I represent Fine, Foundation for Innovative New Diagnostics. I'm the Regional Director for Asia. Thank you. I think the presentation actually reflects three very key priorities and a very futuristic vision. Cardiovascular or non-communicable diseases are going to replace, and you've already shown that in Indonesia now they are the leading cause of mortality and morbidity. So I have two questions and couple of suggestions. The first question is that in addressing the cardiac and cardiovascular and neurological diseases, which you mentioned, the golden hour, diagnosis is very critical. It's not just the cath labs, it is also how soon you diagnose this and how soon the patient can be shifted. So there needs to be some emphasis on developing newer tests, like biomarkers and all, which can be done more point of care at the peripheral levels. And then there is a referral system as well. So while, the location of these cath labs, and you mentioned very clearly that only 25% of the area in Indonesia have these cath labs, 75% do not. Where these should be located should also be complemented by how soon the diagnosis can be made. And we've been working with the Ministry of Health in doing diagnostic network optimization, where we are looking at TB and other diseases and where a health facility or a diagnostic test should be placed. That can actually be replicated for the cardiovascular diseases as well. The second question was related to the estimation of disease burden. And again, what is the vision of the MOH in kind of using this disease burden in policy translation? And the suggestion there is that, use of connected devices. So right now what happens, a test is done for a particular disease, then that data is entered into a software or a tool, and then it gets uploaded. So if these diagnostics are already connected to the Satu Sehat and other platforms, that will actually help, in accelerating the action taken based on the result. Thank you.
Thank you very much for the question. Another question, last question probably. So while we're waiting for another question, Pastor, we can answer the question. I think the first question is quite important here, Pastor, on how we can leverage the use of big data, Pastor, in our programs that you presented today. Because I know that while we're doing this big data utilization, I remember one of part of your project last year on how Indonesia can maximize the use of digital technology, AI, and big data. Probably you can elaborate more on that one, Pak Asnawi, please.
Ya, terima kasih. Thank you so much, Priswita. Thank you. Very good question. One question related with burden disease and suggested to also focus on prevention issue. Let me answer your question by using the example of CKG, for example. We know in burden disease, stroke, for example, is quite often occur in any society, regardless of social economic status at the moment. Similar to type 2 diabetes. Before, people assume that type 2 diabetes is mostly associated with high social economic. But nowadays, all across social economic status facing type 2 diabetes, for example, as well as stroke. So by doing global burden, Indonesia burden of disease, in the future we can estimate, forecast the burden more accurately, not only at national level, but also we aim able to do at subnational level, provincial level. It's wonderful if also can have at district level. You know that sometimes if you look at the Indonesia, some region of Indonesia is totally different with other part of Indonesia. Let's say, look at the Bali, for example. If you see the all health indicator in Bali is relatively almost similar to developed countries. While in other part of Indonesia, still like we feel like we are living in truly in developing countries. So it's great if we can have a burden of disease across different provinces of Indonesia. So then we can move to prevention. Let's see, if we have the prevalence of type 2 diabetes is higher in some region, so then we can explore the main risk factor. So then the prevention strategy is more accurate, more precise. Compare we don't have any Indonesia burden disease. Let's see the example of CKG, for example, related with prevention. We have a data. A lot of people, they never have hypertension diagnosed by the medical health staff. They already suffer for many years hypertension, but they don't realize they have hypertension. So by having CKG, now 65 million already covered by CKG, and we can have the number of people with hypertension, high blood glucose, something like that. So then we can propose a couple things related to a couple strategy related with prevention strategy. So we agree if we focus only on curative thing, our system is not able to cope in the future. This week, a couple days ago, with Prof. Dante, we Prof. Dante launching di Dinas Kesehatan kemarin, launching stroke initiative by Provincial Health Office DKI. By think about like I would like to show in Jakarta a lot of healthcare facilities. Most of hospitals they already have cath lab, for example. So the governor targeted to give the cath lab services in the golden period of time. That is one solution. But think about if we are not focused on prevention. So even though all the hospitals having cath lab services, but if the people not aware, they have they have hypertension, they can control the high blood pressure. So it's difficult for the system work if you only focus on hospital prevention. That's why we see the strategy prevention like CKG is also one of solution we need. What we say to make sure the program CKG will cover the entire Indonesia population in next following year. So this year we target around 100 million.
Yeah.
But then in the following year we can target 100.
Even more than that.
Yeah, even though more than 100. So then we can design also the preventive program, Reswita. The second question, we agree that related with public-private partnership. In BKPK nowadays, we are developing what is the best way, what is the best model private partnership in health sector. We agree. Public-private partnership should be a priority. The second question is related with not only the technology, cat lab also, but nowadays also biomarker is also important thing. There is a good example related with biomarker. Now they develop related with mental health. Think about now the most of program we are treating the people after suffering from mental health. And some research suggests a lot of biomarker can predict the mental health. So we agree. We also need to focus on biomarker related with different type of disease. The third one related with Satu Sehat and burden disease. We can't develop a good Indonesia burden disease if we are not improve our data collection. The fundamental principle having a good Indonesia burden of disease is improving our data collection, data interoperability. So we work on this aspect at the moment. We have I forget you which is the development partner we work strategic, vital
strategy.
We work at the moment with vital strategic. That also related with burden of disease, Indonesia burden of disease. So we improve the data collecting, data interoperability in order to build a good burden disease estimation. I think that's the comment I can answer. Time's up. Thank you so much.
Thank you, Pak Asnawi. I think we don't have much time for this session, but thank you very much, Pak Asnawi, for those answers and also all the questions. But I know that if there are still many questions from the floor, that Pak Asnawi and his team are ready to explain in detail about the programs. And also, colleague, if you notice from the upper side or the left side of this room, you will see like many posters, and then you can see that from those posters in detail about each program that will be presented in our meeting today. So don't be hesitate to visit those posters and ask a question to all officials that stand by ready in front of the poster to be brief and provide more detail on those programs. Thank you very much, Pak Asnawi. Please give round of applause for Pak Asnawi. As we want to, makasih Pak. So let me continue the discussion, the presentation of our programs. I'm very lucky today that I have Ibu Dirjen, Ibu Ami. Ibu Dirjen is one of our important DG. He will present her program on Wolbachia, if I'm not mistaken. But please, Ibu, if you can join us on the stage. Thank you very much, Ibu, for joining us today. I know that you're super busy. You have numbers of schedule today, but you are able to be here with us and presenting one of your important program. I'm not so sure that Ibu Murti Utama or Ibu Ami need to be introduced because I know that our partners have been working with Ibu Ami for years, ya Bu, ya, in numbers of program. She's a director for general for disease control, Ministry of Health of Indonesia. He hold many position within the Ministry of Health of Indonesia. So we don't have much time, so I don't want to read whole of her CV. But let me give the floor to Ibu Ami. Ibu, please.
Thank you, Pak Adit. Every time he says Ibu Ami, actually my full name is Murti Utami, but my nickname is Ami. You can call me Ami. So every time Pak Adit said Ami, don't be confused of that. Okay. Before I start, I just like to give you the proposal. You can scan the proposal. Can I have this slide, please? Yes. Okay. Okay. I just been appointed as the DG for disease control just a week ago.
Congratulations.
Budi is, before I'm the Inspector General, so now I'm definitely as a DG for disease control. So, good afternoon, my dear colleague from the country's representatives and development partners, donors, potential partners, and everyone, ladies and gentlemen. From the disease control, it's only one proposal that we are proposing to you. And actually, I'm a little bit ashamed. On the last slide, we give the numbers for the proposal, not like Pa Asnawi. He's very polite. He doesn't give the numbers. So when I talk to Prof. Dante, the Vice Minister, my goodness, I'm giving the numbers to donors to support us for the Wolbachia. Well, anyway, this is the transparency that I have to share to you. So hopefully my proposal is satisfied for your support. Okay, can I have the background slide, please? So, ladies and gentlemen, we have just made a various effort to control this dengue fever. From the PSN. PSN is one of the, how we can, is an intervention for the environmental. So how we can breed the mosquito breeding site eradications, and we use cadres to find the breeding site. So from this effort, we still need more interventions, more innovations. So what we see here, the high burdens of the dengue in Indonesia is still high. So almost all province in Indonesia is the highest burden. In 2024, last year, we extremely have a very serious problem for dengue. Yeah. We have 257 reported cases, and more than 1,000 is associated with death from dengue. And if you see the average cost for the treatment with the comorbids, it's about 780,000 rupees. And the hospitalizations, it takes 5 until 6 days in the hospitals. And if you see for the disability adjusted life years, it's contribute 0.7%, yeah? And if we see the economic losses, the national level are estimated to reach 15 trillion rupiah annually. So, and then as we know, this transmission risk due to the climate change, rapid urbanizations, and high populations mobility. So this is the backgrounds, how these, the high burdens of Indonesia for the dengue. Can I have the next slide, please? Wolbachia is actually is a bacterium which is found in more than 60% of all insects. Yeah, and this Wolbachia bacteriums block the replications of the dengue viruses, which introduced into the Aedes aegypti mosquitoes. So the first research is implemented with the university from Gajah Mada, Jogja. It starts on the 2017 and they finish on the 2022. So this has been scientifically proven, and it proven to reduce the incidence of 77% and decrease the dengue-related hospitalizations 80-60% in Yogyakarta. And we do this, we extend the piloting through 5 cities, the Wolbachia pilot project in 5 cities, which is in Semarang, in Bontang, West Jakarta, Kupang, and Bandung. We started in 2023. And we complete the Wolbachia implementations in 4 cities. And the Bontang is the one city is completed, but the other one hasn't been completed yet. That's why we really need these the other 4 cities to complete these Wolbachia piloting project, which can make us to impact the analysis of the 5 cities itself. And to reducing the Wolbachia, the dengue fever, it's appeared to be 1 or 2 years. And after the full deployment of the Wolbachia, we can see the mosquito populations will reach 60%. It means that after the 60%, they will decrease the dengue fever incidence. So this is the shifting of the mosquito that we are deploying. Before we deploy for less than 60%, which takes for 6 and 9 months. And afterward, after the 9 months, and it goes to 60%, and we stop to release the mosquitoes. So this is how the techniques of the Wolbachia replacement. And next slide, yes. I can show you this Semarang city. If you see the solid green lines, yeah. We deploy this, the Wolbachia start from the August on 23, and we stop on the July 24. We deploy in for about 1 year. And then if you see the incidence cases in Semarang city, it shows that the green solid lines, it shows that it's growing, decreasing the incidence. But the other lines, which is the dots line, this is the cities that is undeployment with the Wolbachia. So you're seeing the upward incidence trend and still trying to go down, and they come up again on the January 25. So this is the incidence that I would like to show you how these Wolbachia mechanism to decrease the incidence shows us Very good. And I would like to give you the information how the activity plans and the budget requirement that we like to be supported. We like to continue these four other cities, Semarang, Bandung, Jakarta Barat, and Kupang. So we would like to start in the first semester of 26, and we would like to end this 5 project cities in 27. So the activities plan is, the first one is the egg purchasing. So we buy the eggs from the productions. Gajah Mada has the small productions, and we have these Udayanas as well. They have a productions facility, and now we are trying how to develop Biopharma to engage us to be one of the productions of the egg productions for Wolbachia. And the second activities is we release these eggs, and we monitor and evaluate the egg. And then, of course, we need the community engagement. We use CADR. We use CADR to move around the bucket, because the Wolbachia egg, we put it in the bucket. And the CADR goes around and try to put in certain places that were humid and with all the techniques, things that they know, and then they goes of the adult, and then they release the adult mosquitoes. And of course, we still need the technical assistance from experts and from Gajah Mada universities. And this is my last slides. This is the budget requirement for the Wolbachia for these next 2 years, in 26 and 27. If we divide it in cities, we have this amount, in total amount. So actually the total amount in 4 cities, we propose about 3.7 million US dollars, or we can say is 61.9 million rupiah. Now, this is our proposal for the requirement for the Wolbachia implementations for the next 2 years. Hopefully, we are very open for your contributions, support for the dengue fever. As you know that we are now trying to tackle these incidents. So we are very delighted, and I will delighted to see you here. And maybe after this, if you need more information, very techniques, all my colleagues here will support you and give more information. Thank you. Terima kasih, Pak Adit.
Terima kasih Bu Dirjen for your presentation. It's quite comprehensive, and you also mentioned about the successful story in different cities and how we can replicate those programs in other 5 cities, Ibu. So we have a couple of minutes for question and answer, colleagues. So if I may now invite a question from the floor about this specific program. Anyone? So I may use my privilege, Bu Ami, as a moderator to ask you a first question, Bu Ami, Bu Dirjen. I wonder if let's say this, you mentioned in your presentation about the success story of one cities, Bu, but how you and your team can ensure if we can replicate this success story to 5 other cities, given the fact that those 5 cities probably they have like different geographical conditions and different challenges, Bu, yeah. I think that my first question, and my second question would be like, if let's say we reach a success story in those 5 cities, Bu, what is your next plan to ensure that this Wolbachia program can be replicated to more than 5 cities and be more sustainable throughout Indonesia, Bu? Thank you, Bu.
Terima kasih, Pak Adit. If you ask me about the geographic, yeah, Pak Adit, we see that most of the, we have these all the 20% of provinces all are incidents by dengue. So the mosquito is everywhere in most of the province, yeah. Maybe not part of this all cities, of course. Maybe if you have these pegunungan side, yeah, like Papua pegunungan. If you go to maybe very cold cities like let's see, mana? We don't have any cold cities in Indonesia. Yeah, sorry, I cannot give you examples here. But anyway, most of the province are the incidents of dengue. So this is why we really need the support of the Wolbachia project. And the next questions from you is how we can make sure these replicate after the 5 cities. Of course, will be the big project, ladies and gentlemen. We are starting now to see after the 5 cities, we like to expand our project to 100 cities. That's why firstly, we need the commitment for the governors, because the governor's commitment is very important. Because in this scheme, we ask Cicada. We ask Cicada to go to work with us, because without the cadres from the Puskesmas, we cannot go through with this Wolbachia program. So after we know these 5 cities is conducted very well, and we like to go to we have the ambitions to go to the under 100 cities to expand.
Well, thank you, Ibu. Probably question from the floor. Colleagues? Yes, we have Ibu Ye from the ADB. Ibu Ye.
Thank you, Bu Ami, for the presentation of this very exciting initiative. I think that represents one of the latest technologies that we can really take advantage of to tackle disease prevention and disease control. So ADB is very keen to support this initiative. And then, of course, we will be in touch with your office in the new year about this. But my question is actually, how are the 5 cities selected, and how are the 100 cities selected for the national scale-up? I would like to know some of the considerations in this, if you could share. Thank you.
How is the 5 cities elected? Can I ask my colleagues on the side, because I'm continuing their programs actually. Sorry, Pak Burhan, can you answer how the 5 cities are selected? Bisa Pak? Silakan Pak Burhan. Can you come from?
Okay.
So everyone can see you.
Okay. Okay. Thank you very much, Miss.
He's not one of the mosquito, so but he is very keen to do the project. Come on, Pak.
Okay. Thank you very much, Miss. Okay. Number 1 is the 5 cities because the 5 cities Indonesian in the choice. Number 1 is high burden the case to Indonesia. Number 1 is 5 cities. Yes. Bandung is number 1 is case dengue, and West Jakarta, Bontang, and Semarang, and Kupang. Yes, because Indonesia, Kupang is West Indonesia. It's Indonesia. Yes, okay. At number 2, because the percentage density, because the 5 cities is density of people, and the 5 city total population 7 to half million population. Yes. Okay. Thank you very much, Bu.
So it's the incident rate for the cities and the density of the populations. Okay.
So we still have time for more questions, colleague. But before that, thank you, ADB, for supporting this program. So I hope the other partners can join the ADB, Bu, to
Terima kasih.
yeah, to support our goals. Yeah.
Can I give you applause for ADB?
So I wonder if colleagues from the floor still have further question. So if not, I will close the session, Bu. Again, as I mentioned briefly earlier, we still have like a poster outside. So if you want to know more details about the program, please feel free to visit those posters and ask a question to the official outside about the details of those programs. So I will close the session, Ibu. Thank you very much for your presentation and your answers. So give a warm applause for Ibu Ami.
Thank you, everyone. Thank you.
Makasih, Bu. So we will have like break, but afternoon break. But before that, I still have one panelist for this session. So on pharmaceutical and medical devices. So let me invite Ibu Dita Novianti, the Director of Pharmaceutical Production and Distribution, to the stage. Please, Ibu, please give a warm of applause for Ibu Dita. Thank you, Ibu Dita, for coming today. I know that you're busy, and Ibu Dita here will, I think she will represent Ibu Rizka, ya, as our DG for pharmaceutical and medical devices. She cannot present today, yeah, for our event today. But I know that you have like interesting presentation for today, Ibu Dita. I don't want to read your CV, but I know that you've been quite some times in these health sectors. You start your career sometimes in 1998. You hold a bachelor degree from Faculty of Science from Unpad, ya, Bu, ya. And your master degree on hospital management, and then now currently you're still pursuing your doctoral degree, ya, from University of Pajajaran, ya. So I don't want to, focus on your CV, Bu Dita, but let's now focus on your presentation on programs that you'll be represented for our programs today. Please, Ibu.
Okay, thank you, Pak Adit. Good afternoon, everyone. First of all, I would like to apologize because Ibu Rizka, our Director General for Pharmaceutical and Medical Device, cannot join with us, as Pak Adit mentioned before. I will replace her to present our proposal from Pharmaceutical and Medical Devices Directorate General. Okay, can I have next slide, please? This is our proposal. We have 3 proposed activities. The first one is incentive program for pharmacy professional to improve the success of TB patient therapy. The second, piloting Satu Sehat logistic in monitoring drug availability from upstream pharmaceutical industries to downstream until health facilities. And then the last thing is to optimization of medical device safety and quality reporting system through e-watch in healthcare facilities. Okay. This is the first proposed activity. Before I explain the program, allow me to brief highly the current situation and burden of TB treatment in Indonesia. From TB dashboard October 2025, show that the success rate of national drug-sensitive TB treatment has only reached 21%. The target is 90, and the drug-resistant TB, it's less than about 20% from the target, which is only 59%. The low success rate of this therapy underscore the importance of the role of healthcare workers, including pharmacists, specialist pharmacists, and pharmaceutical vocational staff in patient education. For this reason, structured intervention is needed through increasing the capacity of pharmaceutical personnel to their contribution to TB program is exactly optimum. Thus supporting the acceleration of achieving the TB national control target. This initiative is supported by a study about enhancing rural pharmaceutical and tuberculosis patient outcome through a pilot of the pharmaceutical training education monitoring adherence networking, or we call it a teman. In Bahasa, teman means a friend. So we name the program as a teman. The implementation of Teman Pharmacy model demonstrated a clear positive impact on both pharmaceutical capacity and TB patient outcomes. Training provided in 37 TB officers result a significant improvement in their knowledge level. Among the patients receiving pharmacist-led intervention, 81.6% experience a significant increase in disease and therapy-related knowledge, while 10.2% show meaningful improvement in treatment adherence. Clinical outcome further supported the effectiveness of pharmacist monitoring. Pharmacists also play a critical role in patient safety and also therapy optimization by identifying adverse drug reaction in 67.3% of patients and documenting a potential drug interaction in 16.3%. Overall, these findings suggest that the Teman Pharmaceutical model strengthens the role of pharmaceutical within TB care teams and contribute to improve patient knowledge, safety, and clinical outcome. This is the detail of our proposal. I follow Pak Asnawi. We don't put the number here because we're a little bit shy, but if you need it, we can give you it clearly. So this is the detail. There are already activity target there and also detailed activity. The detailed activity, there are 4 points. The first one is to identify pharmacy personnel involved drug sensitivity TB services and training pharmaceutical personnel, clinical pharmacy services for drug sensitive TB patient, monitoring, evaluation, the treatment outcome, and provision of performance incentive to pharmacy personnel. There are 4 detailed activity in this proposal. And next slide. This is our second proposal about piloting Satu Sehat Logistik in monitoring availability for upstream to downstream. We monitoring the availability of the medicine. I think this is the one thing of the most important because especially during the transformation, health transformation, we want to give the better health services to all Indonesian people. And medicine is one of the important thing that must available in every health services. So this is the challenges in pharmacy. In Indonesia, we have geographic uniqueness. We have 17,000 islands and start from Sabang to Merauke. So this is a chance for us to distribute the medicine until all municipality in Indonesia. Key gaps include inaccurate and non-responsive health financing data, fragmented human resource information, and excessive reporting burdens at the primary healthcare facility. In the pharmaceutical and medical device sector, there is no standardized. So I think this is a really big problem for us. Okay, next slide. This slide illustrated that Satu Sehat becoming a platform. They can integrate existing fragmented health system into a single end-to-end data ecosystem. From upstream, it connects production, regulatory, procurement, and distribution system, providing real-time visibility of pharmaceutical and medical device supply. At the core of Satu Sehat Logistik function, as national digital inventory, using standardized master data for product and facilities. At the downstream, the platform integrates utilization and healthcare facilities, recording both distribution of pharmaceutical for government spending and also private sector. And the links this data directly to electronic medical record and prescription. Together from upstream to downstream integration, it will ensure that supply data is aligned with actual clinical use, enabling stronger oversight, better planning, and more resilient national health supply chain. And I think this is very important to us to monitor the medicine around Indonesia. And one of the obligations for government is to ensure the availability, acceptability, and also sustainability of medical in Indonesia. Next slide. This is again the detail for the second presentation. There are five detailed activities. The first, development of Satu Sehat logistic to monitor drugs availability and also price at production, distribution, and also health facility. And then coordination with representative of the pharmaceutical industry, distributor, pharmacists, and selected vertical hospital or RSUD. And then interoperability of Satu Sehat logistic with pharmaceutical industries, distributor, pharmacists, and also with a selected hospital. And we want to try implementing Satu Sehat logistic in the pharmaceutical industry, distributor, and also the hospital. And the last thing, monitor and evaluation of availability through Satu Sehat logistic. We need this system because we have to do the monitoring and evaluation. And I think if we can have an integrated system and also real-time data, we can fix our problem now. Next slide. This is the last proposal from pharmaceutical and medical device. It's about optimization of medical device safety and quality reporting system through e-watch in healthcare facility. Okay. This is the background and urgency why we propose the third proposal. Because we already have the regulation and why we need e-watch application. Until now, we have a challenge that still low awareness among healthcare facilities and medical device marketing authorization holder. And we have to concern about reputational damage, and there is still a lack of trained personnel in using the e-watch application. This is the overview, what is the purpose of our proposal and the scope and also the target. For target, we want to enhance the quality of medical device in Indonesia. Next slide. This is the detail of the third proposal. The activity detail, there are 3 activities. The first thing, training, preparation meeting, training implementation, and also reporting the evaluation. This is the summary of my presentation. That why we propose this 3 of proposal. For this slide, I follow Bu Ami because there's still a number here, but not to detail. Okay, next slide. Okay, that is end of my presentation. Thank you very much, Pak Adit, and back to you.
Thank you, Bu Dita, for the presentation. I know that if you follow Bu Ami's steps, that someone will announce the numbers after this, right?
I follow both our leader. I follow Pa Asnawi at the beginning,
Yeah.
but at the last I follow Bu Ami.
All right. So hopefully someone from the floor can announce their support for this program, Bu Dita. I will open the floor for questions, colleagues. If you have a question for those programs that being presented by Ibu Dita, please feel free to raise your hands. I have one question from the, yes. Please, Pak, identify your name and your affiliation, Pak, please.
Thank you very much for the opportunity. My name is Aditya from Results for Development. So my question is especially about the initiatives giving incentives for the pharmacists or pharmacy professionals, especially to improve the adherence and quality of treatment. Is there any logic behind that? Why the incentives going to the pharmacists? So I want to also share like a bit story. So previously, there was a consortium also incentivizing the facilities, both public and private, yeah, for the continuum of care of TB treatment, yeah, including case finding and case treatment. And we found that additional incentives indeed increase the involvement, especially private providers in terms of case finding and case treatment. Case treatment including the adherence and also the quality of treatment. So why the pharmacy professionals? Thank you very much.
Simple question, Budita. But I don't know whether this is hard to answer. Why the pharmacy?
Yeah. Thank you, Pak Adit. Thank you, Pak Adit, for the question, and thank you, Pak Adit, for the moderator. Okay, actually, this is comes from a directorate. We call it Management Pharmaceutical. Maybe for in-depth question, we can send the question to that directorate, but I will try to answer now. As we know that TB is, when we got a TB, we need a long treatment, 6 to 9 months, 6 to 9 months, and they will get the medicine from the pharmaceutical. They can get from the pharmacy, they can get for vocational pharmacy or another pharmaceutical from pharmaceutical. When they give the medicine to the patient, they have an obligation to give them KIA, communication and information, and also education. Now we know that in pharmaceutical, in healthcare facility, they have a lot of patients. So sometimes they don't give the patient enough KIA. Because of that, the patient won't use the medicine properly. So that's one of the consideration why we give the incentive to the pharmacy or another pharmaceutical. Maybe that is the answer, but I will ask my colleague, I will call a friend because there is another directorate who in charge with this proposal. Thank you, Pak Adit.
Thank you, Ibu Dita. I hope that can answer your question, ya, Pak Aditya. But of course, if you need more details, we are here throughout the session, even until tonight for our main event. Please do not hesitate to ask our team about the details. Another question, probably colleagues from the floor, please feel free. While waiting for another question, Ibu Dita, I think I have one colleague who wants to ask the question, Ibu. But before you pose the question, I have a detailed question, Ibu Dita. You mentioned about the pilot project for the optimization of the what do you call it? The pharma distribution from factory into health services, right? So you mentioned about 1 to 7 cities. can you mention briefly about those cities so everyone can have details on that one?
Okay. We will decide about the cities. There are any consideration when we choose the city.
Yeah.
The first thing, we want to choose Jakarta because there are a lot of distributor and health facilities in Jakarta. And then around Jakarta, because there are a lot of pharma industries are there,
Yep.
industrial areas there. So we will choose another big cities like Jakarta, Bandung, around Jakarta like Tangerang, Bogor or something, and then another big cities in Sumatra, and we will choose one big city from each big island.
Okay, clear. Okay, Mas, please.
Yeah, thank you so much, Ibu Dita, Pak Adit, Eric Salenga from WHO. On the proposal number 2, we just want to indicate that, as you all know, WHO is in the process of finalizing the biennium work plan for 26-27. And we note that there is a similar or related work under Pusdatin that is supported in our work plan, which is on the Satu Sehat Logistic Roadmap development. We're very keen to know later on, maybe we can discuss further how we can interlink the work on the Satu Sehat logistic work under Pharmalkes, because we think that this is really important, making sure that we have a very robust system to monitor the supplies, essentially also to identify where the bottlenecks are, and some arrangements so that we can cope up quickly in order to support the resilience of the health system. So from WHO, we're very keen to help you on that. Thank you.
Thank you, Pak Eric. Yeah, I think we have support from WHO, Bu Dita. I'm not too sure whether this is like more on financing or technical capacity, Pak Eric. But of course, we can discuss that later.
Right.
Probably another question, last question, hopefully, before we take a break, for a short break. So,
I just want to add some question to Pak Angga. We do the what we call small observation that when we give incentive to the pharmaceutical, there will the what we call kepatuhan. Oh, the compliance from the patient to drink to take a medicine is better than no incentive. So I think in the future we can expand this kind of study.
that makes sense, Bu. Yeah.
Yeah, from Pak Eric, I think that is not a question there.
Yeah, it's more about support.
Yeah,
Bu.
okay. We can discuss about it, Pak Eric. Thank you so much.
So, Ibu Dita, if there's no other question, I will close the session. But of course, colleagues, ladies and gentlemen, please feel free to ask more questions. Even after the event today, we have like a full side event and main event for at least for the whole day. Of course, again, I will. This is my obligation, of course, to mention about the posters. Please visit the poster and read the details. We have also barcodes within the poster, so you can download the brochure, the flyers from those posters. So we will have like a short break. I will give the floor back to the MC, but before that, give us a round of applause for Ibu Dita for the presentation and for the question. Thank you, Ibu Dita. Please, MC, terima kasih.
Terima kasih. Thank you very much. Please give a round of applause for our moderator, Bapak Hardityo Suryawanto. Thank you very much. Bapak Hardityo, you may now return to your seat. And as mentioned before, yes, ladies and gentlemen, it is now time for us to take a short break for some refreshments. We will be back here at 3:15 p.m. to continue for our next session. Once again, ladies and gentlemen, we invite you to please enjoy your break, enjoy some refreshment and coffee break provide for you at the foyer area. And we also invite you to please to take a look at the poster exhibition that is also at the foyer area. And once again, ladies and gentlemen, we will reconvene here in this room at 3:15 p.m. for our next session. Thank you very much. Ladies and gentlemen, and welcome back to the side event of the third Indonesia Health Partners Meeting 2025. I hope everyone has felt refreshed already. Can I have a big round of applause as we begin our next session? Yes, thank you very much, ladies and gentlemen. It appears that we are all ready to continue to our next session. Therefore, without further ado, ladies and gentlemen, please welcome back onto the stage our moderator of the day, Bapak Harditya Suryawanto. Please give a round of applause.
Thank you, MC. Colleagues, thank you for joining us again for our resume session. We still have like 4 presenter for this side event, and I hopefully that you can bear with me in this afternoon session, because I know that of course we have coffee, we have snacks, and I don't have any privileges to go to the restroom for the next 2 hours. So I will use my time wisely here, and then hopefully to be more interactive, I will ask you colleagues from the floor to pose any question. Again, please feel free, because we will use this session, and of course the main event tonight, as an opportunity and a good momentum for us, Ministry of Health, to project or to showcase our program. And also for today's event, main event tonight, we will also share our good practices as part of our accountability for our programs to our donors and partners. So let's resume this session. For next session, I will invite colleagues from Health Crisis Unit to give her presentation. I will invite Ibu Widianti to the stage to represent the head of crisis management. Please, Ibu. Welcome, Bu Widiana, ya.
Thank you, Pak Adit.
To the stage. I know that you bear the heavy burden to present the program to the audience, and I think this is one of the big, I think the right momentum, ya, Bu Widya. Of course, we as colleague and participant notice that we are still facing the disaster, yeah, in the northern part of Sumatra, and I know you and your team work very hard in dealing with all the challenges on the ground. Yeah, I know that since last week that we have deployed our Ministry of Health team to the northern part of Sumatra, to the affected area. But of course, our meeting today, we will be very happy to hear you and your team proposals and your thoughts about on how we can increase the capacity of our health crisis team, Bu, and management. Please, Bu Widi, we love to hear your presentation.
Thank you, Pak Adit. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, distinguished guests, donors and partners. Today I would like to present our proposal for strengthening health crisis management for Indonesia. For this proposal, we are support in third pillar in health transformation, in health resilience. So this is our program activities and the budget summary. You can see here we already attach the budget for every activities, but not in details. This is our first activities, strengthening capacity of reserve healthcare workforce. Ladies and gentlemen, as we know, today we are facing many disasters occur in many provinces in Indonesia. Ministry of Health since 2022 established the reserve healthcare workforce to accelerate the mobilization of skilled health personnel in order to enhance emergency readiness and strengthen health system capacity in health crisis affected areas. This mechanism plays a critical role in reducing the risk
and the impacts of health emergencies, ensuring that Indonesia can respond more rapidly and effectively when disasters occur. Currently, Indonesia maintains type 2 tenaga cadangan kesehatan or reserve healthcare workforce. We call it TCK, tenaga cadangan kesehatan. We propose a type 2 emergency medical team which is undergoing the global classification process for EMT type 2 by the World Health Organization. So to meet these international standards and ensure operational readiness and then continuous capacity building initiative, these are essential. These efforts will help develop a pool of trained, competent, and readily deployable personnel, including teams capable of responding to chemical, biological, radiological, and nuclear or CBRN incidents in Indonesia. Given Indonesia's vulnerability to CBRN threats, this activity will strengthen the country's preparedness and response capacity has become increasingly urgent. This includes ensuring the availability of appropriate equipment, the availability of establishing clear technical guidelines, and also to support safe and effective CBRN incident management. So to achieve this objective, this program focuses on several key strategies. The first is capacity building, which we have activities including training on clinical standards such as triage, mass casualty management, and then patient assessment, stabilization, referral and transfer procedure for the patient, and also the CBRN incident management. In addition, the training also covers WASH-related standards, and then including healthcare waste management, sanitation, and vector control, as well as the setup and operation of field hospital. We already equip our EMT Type 2 with the field hospital that we can mobilize to the disaster-prone area. The CBRN management support is further to enhance through the procurement of the essential supporting equipment and the development of guidelines for health crisis management related to CBRN events. So the expected outputs of these initiatives, of these activities and program include strengthening capacity to support the EMT global classification, pre-verification and verification process, also align with international standard for EMT type 2 and improve national readiness to respond to CBRN incident with proper equipment and skilled personnel. So overall, this first program aims to equip our members of the reserve healthcare workforce of the EMT type 2 and ensure the availability of CBRN response equipment. So we have this initiative can be supported by all of our donor here to enhance national health emergency response and capabilities. So we can go to the next program, the second. The second is we are strengthening capacity of emergency medical services. The EMS in Indonesia operated through two key systems. We have the National Command Center or NCC in the Ministry of Health at the national level, and the Public Safety Center or PSC at the regional level. We already have 330 PSC all over Indonesia in district level. Together, these structures play a vital role in ensuring rapid response to emergencies and health crises across province and district. Strengthening their capacity is essential to improve response time, to enhance coordination, and ensure effective life-saving intervention. So to optimize the performance of the NCC and PSC 119 and to improve nationwide emergency response efforts must focus on both capacity building and the integration of information and communication system. Since now we still depend on the third partner for supporting this system, we hope through this initiative we can have our own system in the Ministry of Health. The training also need to ensure PSC personnel possess up-to-date skills and knowledge in emergency and disaster management. So strengthening communication linkage between the NCC and regional PSC centers will significantly enhance coordination and accelerate operational decision making. The key component of this initiative is the development essential system and infrastructure. This includes core application, so the software for the system, and then application supporting hardware, PSC service desk equipment, NCC monitoring center technology, and also emergency ambulance, telecommunication services, and the installation of emergency service networks across 514 districts in Indonesia. By strengthening this system, it requires substantial resources and will be implemented in phases from 2026 to 2027. In the initial phase, our priority will be given to developing a core application and complete with software and license for the application that will integrate national and regional communication and information system. This application will be supported by upgraded hardware to ensure seamless functionality. In addition, the technical and disaster management training for PSC is also needed to strengthen their competencies in emergency response. So for the outputs of this initiative, that we can have the integrated core application and supporting hardware, and as well as a training for PSC personnel all over the district of Indonesia. And then the last is our the third activities or program that we are proposing now, the development of health crisis management plans. As we know, Indonesia still continues to face an increasing number of health emergencies. We now facing 3 big disasters in Aceh, North Sumatra, and West Sumatra that caused many people death and injuries. So from this program, we try to to strengthen our health crisis management through the plans established with clear procedure and then define roles and responsibilities, support accurate resource estimation, and strengthen coordination between national and regional stakeholders. We hope this will robust crisis management plans in place, emergency response become faster and then more accurate and also more efficient. Ultimately, we can reduce the morbidity and the mortality caused by the disaster. And also we hope from this development of health crisis management plans, we can strengthening crisis management planning to achieve several strategic activities. Yeah. First, we are doing the capacity assessment will be conducted to support evidence-based decision-making and then to identify priority funding needs and improve the speed of disaster response. This activity, this assessment will also help reinforce coordination among institutions leading to a more coherent and effective response system. This program also includes the development of contingency plans in disaster-prone district. We already have modules for these activities. We are making risk analysis and prioritization, develop health cluster organization, and making strategic crisis response and advocacy. So this program, we hope will strengthen the technical capacity of local health authorities and improve their ability to plan for and manage complex emergencies. In addition, we also will support the hospital to develop hospital disaster plans in hospital located in disaster-prone district and cities in Indonesia. The participants of this program will be guided through the practical steps of completing HVA and HSI forms and developing a comprehensive hospital disaster plan tailored to their hospital context. And then we will conduct the simulation activities further and to enhance readiness and to ensure that hospital can operate effectively during the emergency. So the plan continues by the simulation to evaluate and to try to implementing what we have right in our plan so it can be implemented during the emergencies. So the expected output of these activities, we can have the regional profiles of health crisis management and then health sector contingency plans and hospital disaster plan. These outputs will significantly strengthen Indonesia's preparedness and response architecture. I think that's all, Pak Adit, our proposed program for our partner and donors in this meeting. Thank you.
Thank you, Ibu Widi, for the comprehensive presentation. I note that you have 3 proposals, programs for the health crisis management. I will give the floor to the audience for question and answer. I know that we don't have much time, but if I can open the floor now for question and answer. Colleagues, ladies and gentlemen, if you have question for Ibu Widi, especially for her proposals and his team and her team. I have one question, Bu Widi. You mentioned about the NCC and PSC as well in your presentation. Can you elaborate more on the role of the NCC and PSC and the linkage between between them, and then how the PSC can normally operate, whether under the instruction of NCC or under the instruction of the each provincial or regional authority. Can you elaborate more, Bu Widi, please?
Yeah, okay, Pak Adit. So if you know the 911 in America, it's almost similar. So the PSG is our 911 in Indonesia, but it's not all linkage with the NCC in the Ministry of Health. We have National Command Center. It's the command center of the emergency call from communities. If they have dangerous illness like heart attack and then or stroke or accidents in the street, they can call to 119. So our emergency call center is 119. They call to 119, and then their call will enter our NCC at the Ministry of Health. The operator will receive the phone call from the communities, and then the NCC will dispatch to the nearest PSC in Indonesia. But with our program that we propose today, we will integrating all PSC in Indonesia to NCC. When people call 119, their phone can directly go to PSC. So it will enhance their response time. Their phone call not enter the NCC first, but they can directly go to the nearest PSC in their nearest area of the people who need the emergency response. So here we want to make our own system, because now we are still depending on the third partner for this information and communication system. So we hope Ministry of Health can have own information and communication system, so we can integrate all PSC in Indonesia with NCC to strengthening their capacity and to reduce the response time for the injured people.
Plus, it's quite surprised for me, Abuya. We
Yeah.
still don't have the what we call the 911, yeah.
Yes.
Nationally, yeah. So I
Yeah.
think hopefully it's going to be like good program, like, and also
Yes,
attract
yes.
interests of our international partners on how they can assist us in building this system, yeah. Because of course we are big country, and then we have like 200 million population, and so ensuring this. The simple numbers, if I may say, from 911 to 119, yeah.
Yes.
It's like
We
we're-
hope, yeah.
yeah,
We hope
we'll
we can
be very
be
happy,
911.
Yeah, 911. Yeah, 119 is
Yes.
quite ear-catching, like,
Yes, yes.
Ibu. So I will invite colleagues if you have like questions for these programs, or at least for this proposal. So if not, so I will end this session, Bu Widya. But thank you very much, colleagues, for your attention. Again, we still have time for more detail about Ibu Widi's program. So if any one of you still wants to, pose a question and need some details, please feel free to ask Ibu Widya. Ibu will be around here in this room and happy to answer a possible question. But again, thank you very
Thank you,
much,
Pak
Ibu
Adit.
Widya.
Thank you.
Thank you. Give warm applause for Ibu Widi, please. Thank you. So our next panelist will highlight about the programs on the health, advanced health, yeah. So without further, not advanced health, for the health workforce program. So I will invite the representative of the health workforce Directorate General, Ibu Ana. Please, Ibu. Good afternoon, Bu Ana. Yeah. I'm happy to have you here. Normally, we have our own session, Bu, yeah, dealing with counterparts on how we can increase numbers of nurses and increase our fellowship abroad. Yeah. So I'm happy to have you here. But I know you're the one of the expert of this health workforce, Bu. So I know that hopefully you can present interesting proposal or program from your unit, Ibu, yeah. So I don't have a CV of Ibu Ana, but I know that Ibu Ana has been dealing with this issue on a health workforce for quite some time, Ibu, yeah. Not only within the MOH, but also she's only focusing on the numbers of our Poltekkes, yeah, throughout Indonesia. So Ibu, please, without further ado, we have almost 5 to 10 minutes, Ibu, yeah, for your presentation. Then we will have like question and answer and discussion with the audience. Yes, Ibu Ana.
Thank you, Pak Adit. Good afternoon, distinguished senior officials of the Ministry of Health, Ibu Dirjen P2, and also Bapak Kepala Badan BKPK, international development partners, and also other country representatives. Ladies and gentlemen, thank you for having me this afternoon. I would like to propose 2 activities to be funded by our international development partners, and there are two programs The first one is to improve the quality assurance of our advanced medical specialty program at our 6 sponsoring institutions. And the second is to develop the resilience health workforce through Asia Pacific Actions Alliance on Human Resources that currently Indonesia is a chairperson. Yeah. So for our first proposal, currently we are having a significant shortage of medical specialists across the nation. Annually, we produce only around 2,700 medical specialists for all specialties, and the education center is only 26 medical schools across Indonesia. And based on our national health plan, we require at least around 70,000 medical specialists to provide medical specialist services across Indonesia. So you can imagine how long we should produce medical specialists if we have only 26 medical schools across Indonesia. So started from 2024, last year, when finally Indonesia have a new law on health, law number 17, year 2023, and continued by the next regulation on government regulation number 28, 2025, 24. Finally, last year, we opened 6 sponsoring institutions after receiving a permit from Ministry of Higher Education to open 6 study programs at 6 hospitals. The first in Harapan Kita Mother and Child Hospital for pediatrics study programs. And the second is at Harapan Kita Cardiologist Hospital for cardiology study program. And then the third is Dermais Hospital for radiation oncologists. And the fourth is Rumah Sakit PON for neurologists. And then the fifth is Rumah Sakit Mata Cicendo Eye Hospital for producing ophthalmologists. And the last one is Orthopedic Hospital Suharto for orthopedic and traumatology study programs. And those hospitals already accredited by ACGMEI last October. So as sponsoring institutions, the 6 hospitals already received accreditation and recognition from the international accreditation body. And we are still working on the accreditation for the study programs. So this project actually be proposed to receive some amount of funding to help us facilitating 6 main hospitals to ensure that they can prepare the accreditation program so that they can meet the requirement and the standard that's set up not only by the SCGME, but also for Lampetekes. Lampetekes is the national accreditation body for study programs in health sector. And I would like to inform you that starting last year, when we start open the study programs and also conduct the selection process, currently we have 2 batches of residents who are studying at our 6 hospitals. In total, we have 109 residents currently studying. And as you can see in the map, you see that many of our residents come from across Indonesia. And you see that some of them come from Java and Bali, but they will not be deployed after completing their studies in Java and Bali. Instead, they will be deployed outside Java and Bali. So you can see that we plan to deploy them based on the national health plan that mostly in Sumatra, Kalimantan, Sulawesi, East Nusa Tenggara, and also eastern part of Indonesia. So that's the main purpose of our program, to make sure that we are not only producing more number of medical specialists, but more importantly, that making sure that the medical specialists distributed evenly, equally to all the country. So for this proposal, the purpose is to strengthen the QA system in all 6 RSPPU or sponsoring institutions through capacity building, development of accreditation-aligned instruments, and also adoption of competency-based assessment. Currently, we are working on milestones of competence from the ACGME that we need to adopt to the national criteria as well. So the target groups are study programs and also the hospitals management. And our role is to lead the coordination, policy stewardship, and also resource facilitation, and also oversight the process. Our key partners include ACGME, Lempetekes, Indonesia Health Council, collegiums, teaching hospitals, and also universities. So there are some institutional and policy bases that that act as regulation. And we have some outputs, guidelines for the quality assessment, quality assurance for the hospitals as sponsoring institutions, and also the workshop report. And the outcomes is we expect that 6 study programs at 6 hospitals will be accredited by Lampetekes and also SCGME. And the beneficiaries is 6 hospitals. And the timeline, we expect to start the preparation in January next year, and also to conduct some workshops and also to accomplish the guidelines. So hopefully by the end of the next year, we will accomplish all the activities. And we don't require a lot of money. This is small money compared to a crisis center, yeah. So we expect to have around 47,000 US dollars. Because for the accreditation fee, the cost would be borne by each hospital, not by us. So this is actually funding for facilitating the process. So that's for the hospitals as in sponsoring institutions. The next one is our proposal regarding our leadership for the AAAH activities. Next, please. Yeah. Yeah. In 2024, we among other 22 member countries from including from EMR, CR, and also Western Pacific regions, we become members of the Asia Pacific Action Alliance on Human Resources for Health. This alliance actually already established a long time ago. If I'm not mistaken, around 2006 or 2007, and Indonesia is among the founder of this alliance. And our program through this alliance is actually to promote best practices and also knowledge sharing among my member countries, especially on human resources for health. As far as I know, human resources for health is maybe not many platforms in the world. And AAAH is actually one of the platforms that currently still exists to this day. And only this year that finally Indonesia is selected to be the chairperson, and I'm the chairperson for the AAAH that will, and I'm serving from 2024 and will resume in 2026. So it's a 2 years leadership. And there's a bad news. Starting this year, previously AAAH Secretariat is always under the Thailand, the MOH of Thailand government. But this year, because of something, I think with the budget restructuring or something in the Ministry of Health of Thailand, that we do not have as much as previous support from, just like previously from the AAA Secretariat. So this is become quite challenging for me as the chairperson of the AAAH to maintain the programs and the activities under the AAAH. So for the next year, we plan to host the conference, the international conference that normally conducted every 2 years, and we propose to continue the theme that previously shared last year, to continue the discussion, especially related to the health workforce resilience and also the adaptation of artificial intelligence technology, the digital technology. So we propose that during next year, we will host the AAAH conference, inviting all the AAAH members. But from our proposal, we do not require fundings for all of those activities. Instead, we require some organization funding, organizational cost, not cost for travel for all the members. Okay, so next, please. Yeah. So our strategic approach will be several webinars in advance prior to the international conference that will be conducted hybrid through online meetings and also offline meetings as well. And we plan to conduct the international conference in Jakarta around October next year. And usually during the international conference, we will also host some side events. So we would also invite some donors and partners to join us, not only during the main conference, but also for some side events that related to the topic of human resources for health. So, and we expect that we will host around 150 participants, and it can be more. And we can also expect to have some partners fair for medical appliances or maybe pharmaceutical products to attend the conference as well. And we expect to start the preparation, especially with the online meetings on January up to September 2026, and the conference would be conducted in October. So overall, we don't require a lot of money as well. So the organizational cost would be around $43,000 US. So thank you very much. That's from my side.
Thank you, Ibu Ana. It's very interesting to see the reality, Buya, from your presentation that we still lack of numbers of medical specialists. Yeah. So you mentioned that you mentioned about the numbers that we still need 70,000 specialists. So if we produce numbers of specialists like almost more than 1,000 for years, so I can say that we need like almost 11 to 12 years to reach that numbers. So that's why your program is quite important, at least in how our healthcare system, yeah, because if we enhance the not only the logistic but also infrastructures of our health system, but without the health specialists, so we won't move anywhere, I guess, yeah. So that's the rationale of this program. So moving from the university-based education to hospital-based working together from
not moving.
Okay, working
the two
together.
systems still
Okay,
working together.
Alongside both university based and hospital based is quite important ya Bu, on how we can quickly reach that numbers ya Bu ya. So I will open the floor for those who are interested in more detail, or if you have question about at least two programs that presented by Ibu Ana ya. Please feel free, colleagues, if you have questions. Yes, I have Pak Pandu from the World Bank. Please, Pak.
Thank you, Pak Adit. Thank you, Bu Ana, for the presentation. I think we've had a long history of collaboration between MOH, especially the Health Workforce Unit, and the bank. I think our first interaction was during HWS, or Health Workforce Project, years ago. So I'm very interested in your first proposal and overall proposal. I just would like to bring to your attention that actually there are 3 donors that are contributing to MDTF, or Multi-Donor Trust Fund, to support the health system transformation agenda. And your first proposal is actually could fall easily into one of the activities that can be supported. This is a recipient executed trust fund managed by Bureau of Planning. So I think you need to reach out to Pak Budi, sitting back there, for the proposal, because this is an interesting proposal and we would like to see it further. Secondly is that the World Bank, through iSphere project, also has had similar experience in terms of bringing in Indonesia accreditation mechanism into or following the global standard. The primary healthcare accreditation system is now accredited by ISQA, International Accreditation. So I think this produces valuable learning experience for RSPPU. So I also would be more than happy to facilitate the discussion between the team that support the obtain of the international accreditation for primary healthcare facilities with the RSPPU. So I'll stop there, Pak Adit, and back to you. Thank you.
Thank you, Pak Pandu, for your ongoing support. Bu Ana, I know that Pak Pandu have like more details for the ongoing projects. So not only you can reach out the Bureau of Planning, but of course probably we can use also this opportunity to encourage other partners also to at least to participate in that program proposal, especially for the enhancing the quality assurance for this hospital teaching base. Are there any colleagues who wants to pose a question and they'll ask for clarification for those proposals? So Ibu Ana, if you want to, okay.
Yeah,
please,
I would like to respond to Pak Pandu. Pak Pandu, thank you so much. This is a very exciting news for me because the World Bank always being supportive, and also you already have experience with assisting the accreditation of the primary care institution. So I believe that the support and also not only financially but also technically from the World Bank would also help us in facilitating the RSPPU. Thank you so much.
Pak Adit, just to mention, I forgot to mention that the Multi-Donor Trust Fund is supported by DFAT, US government, and also Gates Foundation. Thank you.
Okay. Thank you for the sponsor message, Pak Pandu. I think that will encourage other partners to to join the team, yeah, to join the winning team and provide more chip in. Any other question from the floor, colleagues? I know this is quite important, Bu, yeah, program for, again, as I mentioned earlier, we have the infrastructure, but we don't have the adequate workforce to fill in all the health facilities across Indonesia. So increasing numbers of the health workforce, especially the specialists, is quite important for us. That's why we put like a high priority, Bu, yeah, in increasing the numbers of specialists across Indonesia. So I know that we are not only focusing on that specialized program, Bu, yeah, but also we also focus on numbers of different scenario, yeah, like enhancing our Indonesia's diaspora, yeah, and inviting them to also to contribute to Indonesia health sectors, and also we have like a different avenue on how we can increase our fellows abroad, yeah, to enhance the numbers of specialists in Indonesia. If we don't have any more questions from the floors, I will stop the session, Ibu Ana, yeah. But thank you very much, Bu, for the presentation. Again, colleague, if you have further question, please feel free. We will be here until 9 p.m. Today. If you still have a question about this program, you can contact Ibu Ana and and her team outside, close to the posters. Thank you very much, Ibu Ana. Please give a round of applause for Ibu Ana. So we still have two presenters for this afternoon program. Please bear with me, colleague. I will now invite Pak Sunarto, yeah, from Director General of Advanced Health to the stage. Pak Narto, please. Welcome, Pak Narto, and thank you for being able to to present today, Pak Narto. I know that you're super busy on how you manage all hospital and health facilities across Indonesia. So we are happy to have you here, Pak. We have like almost 10 to 15 minutes, or even 20 minutes. Yep, 10 minutes for presentation. Then we will continue the discussion, Pak. Pak Narto is Secretary of the Director General of Advanced Health, ya Pak, ya. Pak Narto he's a medical doctor. He's quite active, not only heading the health facilities in Java, but also across Indonesia, from puskesmas, primary healthcare to different primary healthcares across Indonesia. And now we are happy to have him in the headquarters, dealing with the health facilities and also a hospital in Indonesia. Please, Pak Narto.
Okay, thank you.
You have the floor.
Pak Adit. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon for everyone, distinguished guests from Ambassador, and special for Bu Dirjen, Pak Kaban, and all of you. Behalf from Director General Advanced Health, I want to present maybe 5 proposals for you, all of you, and I hope I can have a good feedback from all of you. Okay, outline, yes, after this. Okay, in RIBK like a National Health Master Plan in Indonesia, we have 6 pillars, and all of you have known about that. Yeah, primary services transformation, advanced health transformation, health technology transformation. Specific for advanced health, Director General Advanced Health, we dominate in advanced health transformation. Our aim through the pillar 2, we have the 4 aims. Yes, increase hospital networks is the first and so important. High quality standard, just not increased hospital facility, but we go to high quality standard services and affordable to accessible advanced health care services and enhance 10 priority disease services. Our 10 priority like cardiology, cancer, uronephro, maternal and child, maybe like infectious, TB, and etc. for the 10 priority. For the next, how Director General Advanced Health to have goals, we describe two aim. The first is as enhancing access and affordability of service. Yeah, so have access. And the second, how we improve the quality of service. So we have access, and the second is quality services. Next. Okay. Director General of Advanced Health separate our program with the 3 level. It's a national level, provincial level, and district or city level. In a national level, we more strengthening in infrastructure and service capacity of Ministry of Health Hospital. Ladies and gentlemen, till now we have 41 hospital owned by Ministry of Health. We have strengthening about the, I have told you about the cancer, mother and child, strengthening cardiology, cardiovascular, and maybe strengthening access to referral health services in Eastern Indonesia. In a provincial level, we go to focus for the cancer, cardio, stroke, and uronephro and maternal children program. And the district or city level, we have a development of comprehensive and high quality hospital in remote area, in a border, in archipelago area, we know is DTPK, through the quick win programs. From President Prabowo, we have a quick win, 3 quick win. One of that is to build hospital in district. We have still now, we still programming, building in 66 district hospital. In 2024 till 2025, we still programming in 32 hospital. Next. Okay, this is our first project proposal I want to share with you. Like Bu Ana in a health workforce, till now Indonesia still lack of specialists. In this map you can see how the distribution of 7 essential medical specialists in Indonesia. The 7 essential medical specialists in Indonesia like internist, obgyn, pediatrician, surgery, pathological clinic, radiology, and anesthesia. It's a 7 special essential. We can see maybe we have a 98 district or city still have maybe 25% complete. Now we have a challenging about this. So next slide. Okay, in the first project, we want to propose you how we build the building excellence in service and education. We combine between services and education in a hospital. Because the function hospital, we know about the services, teaching, and research. Now we still have want to propose you about the how we strengthen 22 potential hospitals to become high-quality specialist training center. How we do it? We can upgrading infrastructure, enhancing diagnostic and surgical capacity, and providing advanced medical equipment. All budget we need, maybe Adit is so big budget, Adit. We need maybe US dollar like 615 million. In Indonesia, maybe 90 trillion, yes. We divide the 2 scheme in 9 hospitals in our left side is a hospital, 9 hospital, has become to the Blue Book in Bappenas in 2024. We hope 2026, the Blue Book become the Green Book. But we still need 11 hospitals that require funding to upgrade and strengthen the infrastructure. Is all of that is our hospital, ministry hospital. Like Adam Malik in Medan, Rifai Abdullah in Banyuasin, West Sumatra, South Sumatra, Persahabatan in Jakarta, Suraji in Klaten, Surakarta in Solo, Benboy in NTT, Reta Toto in Minahasa, Kandau in Manado, Tajuddin Khalid in Makassar, Wahidin Sudiro Hosodo in Makassar, and Johannes Lemena in Ambon. So we need 11 hospitals to do it. The second proposal is how we unlocking potential. Because our new regulation is law number 17 and government regulation number 28, it's not have a specific hospital. Specific hospital will transformation to general hospital. So now we want to upgrade 70 specialist hospital into fully functional to general hospital through expand infrastructure and upgrade medical equipment. We need still US dollar 478 million around that. The three projects we call is a biomedical and genome science initiative. It's our new program in end of 2 years. We need our precision medicine about Big GSI is very new program from us. We have no Indonesia local genomic reference data till now. So we want to we want to have a sample how to about the local genomic data or our to make the precision medicine. So our expected outcome is 30,000 new participants recruited for a year, genetic tests implemented in hospital, pharmacogenomic result as evidence to the doctor in prescribing personalized medicine to reduce side effect. It's called precision medicine. Maybe budget around US dollar like 30 million about this. Okay, the next. Okay, I have maybe 3 proposals about this, about how we improve the quality. The first is a transformation hospital practice through antimicrobial stewardship. You know, about antimicrobial stewardship is a general issue for the global health now. We need precision medicine to have antimicrobial stewardship to do. What action plan we need? Our action plan is, the first is conduct nationwide antimicrobial stewardship, self-assessment, how the hospital to self-assessment about the antimicrobial. The second is, the hospital can implement in capacity building workshop on antimicrobial stewardship. So make an assessment, make a workshop, and the 3 is post-workshop monitoring and evaluation. We need more monitoring and evaluation post-workshop. And the last is to strengthen national antimicrobial surveillance system. The budget, maybe we need 63,000 around that. Next. The second is advanced patient-centered care. Advanced patient-centered care is so related about the patient experience in hospital. We need more we need more instrument how to measure the patient experience. We say like a PRAM, patient reported experience measure, and PROM, patient reported outcome measure. What the function that is to ensure the health worker, hospital management can receive all patient experience to make better services in hospital. Our action plan maybe is 5, Mr. Adit. It's a preparation like a team formation, building team, to make a FGD workshop, piloting to produce the valid instrument, harmonization and dissemination. It's maybe need US dollar like 130,000. Next. The last maybe strengthening organ and tissue transplantation service. In Indonesia now, till now, we don't have about the system. How come we reach our people want to donor the organ, like RAN, like eye, and we didn't have the system like this. So we want to build the system to National Integrated Organ Transplant Information System. Is to significant to improve transparency and accountability across all stages of organ donation and transplantation. Maybe it's just in Indonesia, 518 million about this. Maybe this is the last my proposal, Mr. Adit. Next. Okay. Thank you for all your attention. We hope we can prepare about these 5 projects to make better health services and better health achievement in Indonesia. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih. Thank you, Pak Sunarto, for the comprehensive proposal. You have 5 proposal and you delivered under 15 minutes, Pak Narto. It's quite comprehensive, but I know that we need more details on that one because I know that some of the program is quite interesting. Like for example, like the last one you mentioned about on how we can build the national information system or national registry, yeah,
Yes.
for donor for the
organ recipients.
Yeah, organ transplantation. So this is quite interesting. I assume that we still don't have that kind of system, yeah, Pak Narto. Yeah?
Yes.
Yeah, and because I know that we have pipeline, yeah, on how many donors. It's more about supply. And
many
demand,
donors can register and many recipients can register, and we can enhance some of that.
Okay, I think that's a very interesting project, Pak Narto, on how we can also match the supply and demand on the organ transplantation. I will open the floor to colleagues who have questions or curiosity about those programs under Pak Narto and his team. Please feel free to raise your hands, colleagues. Pak Narto, I know that from your first program that you also want to increase numbers of specialist doctors, ya Pak ya.
Yes.
But correct me if I'm wrong, Pak Narto. I noticed that from Ibu Ana presentation, Ibu Ana focus on the quality, but your program more focus on the,
infrastructure.
Infrastructure, yeah, on how you better prepare the 2022.
All is in 22, but
Okay.
in 9 hospital is become 2 blue book in 2026.
Okay, so 11 on blue books and another 11 on.
Yes,
Yes,
we
for-
still proceed
for another
to the
proposal.
audience. Yes.
Okay, I think that's quite important. I mean, like that's quite also provide us with more linkage with Ibu Ana proposal, yeah.
Yes.
On how we can Ibu Ana's program can enhance the quality, but your side is more on the infrastructure, ya Pak. Because we know that we have many hospital, but in order to enhance the hospital-based education, we need to enhance the infrastructure of those hospitals. So I open again the floor to colleagues, participants who wish to know more detail about this program under Advanced Health Directorate General, please. Colleagues. Anyone? I know this is critical time, but we don't have any more coffee break. So, so, Pak Narto, if you can give us more detail, because I know that you have like a lot of proposal under your programs, but if you can have more detail, especially about the last one, about the national system on
Yes.
donor transplantation. Can you elaborate more, Pak, about the timeline, about the targets, yeah, on how we can develop this national system, Pak, please?
In about the transplantation, actually now is going on. Transplantation is the going on, Padit.
It's an ongoing project.
Going on now, as the transplantation activity in hospital is going on. But till now, we didn't have the system information, national system information about the transplantation. So we need about the registry, about the donors. How many people in Indonesia want to donor the organ, and with accountability, they can input in our registry in a system, and we should have a data how many people in Indonesia need an organ. So we avoid about the cell organ, illegal cell organ about this, because we want to accountability, want to transparent who want to donor, who want to the organ about this. Maybe like that. Got it.
Yeah. Thank you, Pak Narto. Another question, at least for me, from me, Pak Narto, about the biomedical and genome science initiative, or national genome project, because we know that we still lack of local genomic reference data, Pak Narto,
Yes.
and on how we can enhance. And I know you, in your presentation, you provide us with the timeline based on our national medium terms development plan, and so hopefully we can reach numbers of 400,000 genomic data,
Yes.
in 2000.
Every year we have a new target about the to recruitment, to have a sample.
Yes. But my question will be more on the how the infrastructures on each hospital can facilitate or ready for that collecting data. If you can provide us information on our current program, which hospital are ready, and then how many hospital are needed for that genomic collection and analysis, Pak?
Yes. Currently we have a hub for 10 hospital. 10 hospital like Jantung Harapan Kita, hub for BGSI for cardiology. In the Mahatmarjono, hub for neurology. And we have maybe 10 hospital become a hub for BGSI. But this program is how we recruit a sample, and we hope maybe next year or two years more we can have a sample so many people genomic in Indonesia. So there's a target maybe 10,000 or 20,000 is like how we recruitment the target to the sample.
So the question will be, I think the program will be more on how we can enhance the collection of data, with the support of the partners, and also how we can conduct the study and analysis for that genomic data,
Okay, maybe I cannot explain of all because I'm not expert of that. Maybe if someone need information about the BGSI, you can contact Bu Indri or BGSI center in RSCM or in Percetakan Negara. We can contact about that. Yes.
Thank you, Pak Narto. I know Ibu Indri is somewhere here, and then she'll be around for at least for the. Okay, thank you, Ibu Indri. So if anyone who wants to know more about the BGSI program, we have Ibu Indri in the room, and then of course she'll be around for our main event tonight. Pak Narto, I don't want to use all of your time, but of course thank you very much, Pak, for not only for your presence here, but also for a comprehensive presentation, Pak, and
you.
answering at least my question, not the, not the audience question. But I know that hopefully, colleagues, if you still have like a question, we have Pak Narto here, and then again we have poster outside. Feel free to ask more detail, and contact our and Pak Narto team for further details. Thank you very much, Pak Narto.
Okay, thank you. Good afternoon. Waalaikumsalam.
Please give warm applause for Pak Narto. As promised, colleagues, we have our last presenters today for our last presentation. He will tell us more about the programs on primary healthcare and public health laboratory. So without further ado, let me invite Pak Imran, to the stage. Please give a warm welcome to Pak Imran. Thank you, Pak Imran, for your presence today, Pak. We are happy to have you here representing Ibu Dirjen, Ibu Endang, Pak. Thank you. I know that some of our DG still have like different meetings with Ministry of Health, but of course your presence is quite important. You can explain to us about the numbers of programs under Ibu Endang and also your team, Pak. Pak Imran, Dr. Imran Pambudi is Director of the Vulnerable Groups Health, Pak, if I can translate it into English. And he's a medical doctor from Universitas Erlangga, and also he's been around for quite some time within the MOH in different roles, including Director for Mental Health, and also Director on Prevention and Management of Infectious Disease, Pak. And also he's, if I can say that he's a quite expert on TB, Pak. So we travel to Union last 2 weeks in Copenhagen when where you were there as one of the experts from Indonesia in tuberculosis. Pak, we have like almost 30 minutes, Pak, for presentation, also question and answer. Please, Pak Imran, floor is yours.
Yeah, thank you, Pak Adit. So good afternoon, everybody. Mohon izin, Bu Dirjen, Pak Kapadan. Yeah. So I represent the DG of Primary Care and Community Health. So I'm here to present several proposals, in our Directorate General. Slide, please. So our Directorate General aim is to making people healthy through strengthening services, delivery system, and also providing health service by life cycle, and especially in the primary health care. So I will present about this one in two big groups. First, in strengthening service delivery system by providing equipment, infrastructure, strengthening management system, and also quality improvement. So if we're talking about service delivery system, especially in the primary health, we're talking about puskesmas, about laboratory, wastewater, and also accreditation, because this one is also important, how we can maintain the quality services, especially in primary health care. And the second, I want to also present about providing health services by life cycle with attention to vulnerable population and shift towards promotive and preventive approach. So if you're talking here, we're talking about healthy environment, immunization, mental health, and also eat healthy and nutritional meals. Slide, please. So our first group of proposal, we're talking about services for vulnerable population. So in this big proposal, we have 4 proposals. Yeah. First, we propose about health service for persons with disabilities. So I think in the disability, now in Indonesia, we have 15 million persons with disabilities in Indonesia. And I think these numbers will increase because our life expectancy is higher. Our non-communicable disease non-communicable disease prevalence is also increased, and our neonatal mortality ratio is decreased. So it means that the babies that maybe 10 years ago died, now they are still alive. But the quality, maybe we have the problem for the quality. So it means the disability will increase year for year. And our gaps now, especially in the puskesmas, only 2% of our puskesmas can give services for disability person properly. So we need to support we need support to develop health services for persons with disabilities through like piloting, for the providing physical therapy, and also improving the health workers. And we also have some piloting with Finlandia, to have tele-physiotherapy, because I think most of the disabilities need physiotherapy, Padit, and we can see here in what we call in hospital, the queue is very long for this one. So we try to have tele-physiotherapy. So we have a module to who can be learned by the disabled person, and also the family, how to make a physiotherapy. And for this proposal, we propose around 31 billion rupiah. And the second, we propose to about hotline service for suicide prevention. So from the previous presenters also, they want to also propose 911, 991, So this, our hotline service suicide prevention is linked with these services also. We call it healing119.idea. So it's, now we already relaunched these services since August. So since August until November, we have more than 500,000 calls. It means we have around 400 and until 450 calls every day. So it can reflect that our mental health, what we call a problem, I think is significant one. So we want to expand and also expand our services. We need to have more robust system, more what we call the one who can give the consultant. So we need around 19.6 billion rupiah for that one. And the third is community-based mental health services. Since our the mental health problem in Indonesia, I think not only Indonesia but throughout the world, mental health problem is increasing. So we need the good and quality primary health care who can serve mental health care. So until now we have around 47% out of 10,300 puskesmas. So we need to improve them, improve the capacity of the puskesmas of the mental health by using the technology, and also we have to strengthen the networking between puskesmas, and the hospital. So for this kind of these services, we also have what we call a discussion with NUS and Duke NUS with the Singapore to have more networking with the, we call it Empower, Pak Adit, this one. And the third proposals is health services for victims of violence against women and children. So we can also identify now that the number of violence against women and children is increasing. Yeah, and also the violence of the children, yeah, because of the mental health also is increasing also. So we try to have, or we want to develop and monitoring with the MOOC module of the management of the victim of the violence against women and children. And we propose for this ones around 1.6 billion rupiah. Next, please. The second big group, yeah, next, yeah, is primary healthcare service delivery system. We have three proposals here. First is strengthening quality of the clinical management of the primary care frontline. So we identified there is a very gap, yeah, uneven primary healthcare quality, high preventable deaths, and also the rising of NCDs and mental health burden. And we need the support to standardize digital clinical guidelines, workforce training, stronger gatekeeping, and also enhance governance and digital integration of private providers. There is some key activities here. Yeah, some of them are also MOC, yeah, with the training. Yeah. And the second is reaching the last mile, the strengthening primary healthcare in remote and very remote area. So in my my notes here, there are 2,652 puskesmas in the remote area, remote and very remote area. So it means that we need to increase our capacity, yeah, for the remote area. Especially now, you also know that we have some disasters, yeah, and most of the people in the remote area is suffering. So we need the support to technical guidance for primary healthcare tailored to remote and very remote area. And also, I think one of our proposals is how we can use the technology, yeah, by telemedicine and digital technology who can link from between the remote area to the urban or the referral system. And the third, the proposal is reimagining primary healthcare for urban communities. And I think now the urbanization is faster, yeah, especially if we link with the climate change. Climate change tends to make people move, yeah, from the rural to urban. And I think it should be anticipated for this one. That's why we need technical assistance, capacity building, urban health data tools, and also multi-sector coordination. Yeah, slide please. The third priority is public health laboratory. So based on my experience here, laboratory is very important, especially not only diagnosing diseases, yeah, but also how we can strengthen our health security. So that's why we need to improve, yeah, our public health laboratories, yeah, especially also like I mentioned before that climate change, yeah, Pak Adit, is also change everything. So the laboratory, public health laboratory is very important. So the purpose and objective of this proposal is to strengthen laboratory capacity, facilitate transfer of the technology expertise, enhance capabilities for detections, surveillance and response to public health emergency, and also support alignment with international net framework like IHR, JSSA, and also ISO standard. So we propose the activities that we want to have 5 expected output. First is improve diagnostic accuracy and turnaround time. Second, competency-based trained workforce. The third, standardized SOP and strengthen QMS documentation. Upgraded biosafety practices. And the last is strengthen surveillance, data quality and reporting pathways. So for the proposal, we propose around 2 billion, 2 million US dollars for this one. Slide, please. And the next is about under 5 development monitoring and adolescent health services. We have 2 proposals. The first proposal is strengthening development of monitoring for under 5. So from the problem, what we have in Indonesia, one of the problem for the under 5 is around 12% of children whose development is not appropriate for their age. So it's not only about the weighing, but the development. I think this is also important for Indonesia, of how we can reach Indonesia Emas 2045. Because if we have only what we call the muscle but no brain, is no what we call is not used for this one. Yes, I think this is should be balanced for muscles and also brain one. So what we need to support about that one is develop the updated guidelines, capacity building for health workers, cadres, and also PAUD teachers, availability of facilities and infrastructures, including the SDDTK kits, forms, charts, and guidelines. The second proposal is strengthening adolescent health services. So the gap, I think most of the problem now for the adolescent is about the mental health also. So we can see here the depression, the numbers is 1 in 50 individuals aged 15 to 24 years suffer from depression. So it's around 2%. It's quite high. And also sexual violence, is also here, and also smoking. I think Indonesia is the highest, the youth smoker, Pak Adit, So I think it's the smoking or the smoker will be lead to another diseases. And also what I remember that smoking is the gate, to nafsa, to addiction. So I think we should prevent the adolescent of having smoking. And what we need to support is technical assistance, capacity building, and also community engagement. Next, please. And this is the last of our proposal is health promotion and community health. So if we're talking about health promotion, we look about the health literacy. So our health literacy is quite challenging. So in adult population in Java, the one who have adequate health literacy is only 46%. So it's in Java. So it means that in the national, we can imagine, I think lower than that one. So that's why we have 3 proposals. First proposal is piloting of occupational health posts to improve health access for informal workers. So informal workers I think is very important one, because Indonesia, we have more than 60% of informal workers. It's also discussion, yeah, before in Kemenduk Bangga, yeah, this afternoon also, that because of our what we call our informal workers is more than 60%. It's quite difficult to have what we call a pension plan, yeah, a pension plan, yeah, insurance system. So that's why we will talk later about this one. And what the support that we need first is provide technical support and innovation in the piloting, development guidelines and technical instruction, and also manuals, capacity building for health officer and cadres in 18 provinces, and also how to monitor and evaluation. The second proposal is communication strategy for remote indigenous communities. So again, remote areas is also important for Indonesia. So we can also imagine that I think in Indonesia have more than 100 what we call language, yeah, local language. So I think we should develop locally for the message, health messages for them, yeah. So what support we need, that we need to plan and cross-sector coordination, consultant to support the communication strategy for remote indigenous communities, provision of information, education, and communication materials, and also how to can make monitoring and evaluation. And the last proposal is sport, medicine, and wellness program. This is also important one. Yesterday, we have big event in Senayan, yeah, GBK, that what we call gather all of the sports organization and also communities. So the Ministry of Sports and Youth, yeah, they want to encourage the wellness and also encourage the youth to have more healthy lifestyle also. But besides of that one, so we have the numbers that national injury prevalence rose from 8.2% to 9.2%. So because of the hype of the sports, but some of the youth and also person, they don't know how to prepare. So that's why the injury is also increased. And the second gap is because of the lack of the sport medicine specialists is very low. It's only 122 nationwide. And also over 30% age 10 plus are not sufficiently physically active. So what support we need, that we want to make a modeling, the capacity building of health workers for basic sport medicines. It includes GP training, national sports medicine guidelines, and also sports medicine corners and wellness program in selected health facilities. And also we will improve or make more frequent about the campaign, monitoring, and evaluation. So I think that's all, Adit. It's quite many proposals from our Director General. I hope that all of you can think and support us. Thank you. Back to you, Pak Adit.
Thank you, Pak Imran, for presenting the proposal program for Director General of Premier Healthcare and Community. Pak, it's quite comprehensive. I note that you have like quite big numbers of programs that dealing with the primary healthcare and also directly benefited the communities, ya Pak, ya. I know that from your presentation, I have like before I pose question to the ask a colleague from the floor to for having a question. I'm intrigued by the fact that we still lack of public health laboratory, ya Pak, ya. I am curious to know if you have, at least if you have numbers, Pak, about how many public health laboratory that we currently have across Indonesia, because I know that in order to support the screening and also in order to analyze the data from the health screening, we need that facilities, Pak, ya, laboratory network for our public. So if you know currently the numbers and from your programs to at least to twinning program for public health laboratories, do you have any targets in terms of numbers, Pak, on how on how many numbers of proper laboratories that public laboratories, ya, Pak, that we need across Indonesia from that current numbers, Pak, please.
Yeah, thank you, Pak Adit. Well, if you're talking about public health laboratories, we can define into 5 tiers. Yeah. First tiers is the laboratory in Puskesmas. Second tier is in the district. Third tier is in the province. Fourth is regional, and the fifth is in the national level. So I think for the first tier, we need all of the Puskesmas, they have laboratory, yeah. Even though we know that the quality, yeah, and also the what we call the numbers of the test is also limited. But from our record, yeah, from tiers 2, 3, 4, and 5 throughout Indonesia, nowadays we have less than 300. So it means that if you talk about district, now we have around 520 district, right? So it means that not all of the district have public health laboratory. And also for the third tier, for the province, what I remember, I think around 4 or 5 provinces still don't have public health laboratory. It means that if they have samples, yeah, or yeah, for example, like outbreaks, yeah, that cannot be handled in the district, they should refer to another province. And it's costly, and it's also need times. So if you're talking about fast response, yeah, for the communicable disease, it's what we call is quite long way to go about that one, Adit. So that's why we need to strengthen our public health laboratories.
Yes, thank you, Pak. I will give a chance for colleagues and also Bapak Ibu participant. If you have a question or any you need more detail about those programs, because I know Pak Imran and his team propose quite numbers of programs that directly link to the community health. Yeah, is quite important for us that you know we have programs, numbers of programs that directly to the health communities. So, colleague, if you have questions, if you need more clarification from Pak Imran, please, if you have. Okay, Pak, please.
Thank you, Pak Imran. I'm Dr. Sarabjit Chadda. I represent FIND. I think my question is related to the public health laboratory. I think that's a interesting and a very priority area which needs to be focused on. I just wanted to clarify on a point that are you also looking at integrated public health laboratory concept, where you are using more of multiplex platforms to test multiple pathogens. So, for example, now you have molecular tests which can be used for TB, for hepatitis, for human papilloma virus, and others. And also the concept of an integrated sample referral system, so that you're not using a sample referral only for one disease, but for multiple diseases. Thank you.
Yeah. And that response, yeah. So thank you, Pak Sajid. So I think those two, what we call, two principles that you offer is very important for us, yeah, because I think if we can integrate that one, we can reduce the cost, yeah, Pak. And also the workforce is also, we can reduce the workforce. Because nowadays, what I understand, since I am also the acting director of facility and quality primary health care, and also one of my duty is how to supervise the quality of puskesmas and also labkesmas. So I think our big challenge is about the human capital, Pak. Because especially in the remote, yeah, like in the eastern part, even though we can procure the machine, yeah, but what we call, to operate this one is quite difficult to find in the eastern part. So that's why I fully agree to your statement that integrating, yeah, the machine, the samples will be very important in the future, how we can define our strategies, yeah, in the public health laboratory. Thank you, Pak.
So I think it's more on not only about the infrastructure, Pak Imran, but also about the capacity for those who work to operate those facilities, Pak, yeah, on the laboratories. It's quite interesting, Pak. Any other question, colleagues from the floor? If you still have a question. Yes, Ibu Rasmita.
Okay.
Please.
Thank you, Pak Imran, for the comprehensive program. We are interested with the occupational health program. I think one of the critical stage for worker is that when they enter retirement phase. When they enter retirement phase, they only rely on BPJS as their healthcare insurance, in which not all diseases or preventive access are covered by BPJS. In your program, is that also touch when they are retired? What will be the healthcare program we provide for this elderly group population? For example, for them to get routine medical checkup or for them to get basic vaccination like influenza or herpes zoster for this elderly group. Any thoughts on that, Pak Imran? Thank you.
Yeah, thank you. So it's very interesting, yeah, that maybe 2 hours ago we discussed about that one in Kemenduk Bangga. So we have discussion with the Minister of Health, Minister of Kemenduk Bangga, PPJS, and also PPOM, KKSK. So one issues that emerge is also like that one. So how we can provide not only healthcare for the pension plan, yeah, because like I mentioned that 60% workers are informal in Indonesia. So it's quite challenging to what we call to pay the premium, yeah, before they are in the elderly. So that's why the fourth minister have the decision to make another meeting for that one, because it's not only what we call the problem or the program in the Ministry of Health, because it's not only about health. It's not only about the diseases, but also how to prevent the, what we call the elderly to have what we call the suffer, yeah, from their aging like that one. So yeah, I cannot say that one, how the program, but what I believe in previous discussion, yeah, they will have discussion, especially because the OJK is also raised this issue, Pak. And they have the, what we call the numbers that from their presentation, yeah, what I can catch is, this is the elderly problem, the elderly numbers is increased because in 2045, 20% of population in Indonesia is elderly. So 1 of 5% are elderly. And nowadays, only less than 20% from the elderly has their pension. So most of them rely on their family, rely on the children, how they can have what we call food and so on. So I think this is very important. Thanks for raising the issue, but we should have more discussion, not only with our colleagues from another ministries, but also from the partners. Thank you, Pak Adit.
Thank you, Pak Imran. Before I close, is there any more thoughts, questions, colleagues? So, if not, Pak Imran, thank you very much, Pak, for your comprehensive presentation, Pak. Of course, we have a numbers of quite interesting programs. I have a lot of questions, to be honest, Pak, but we still run out of time, Pak. But hopefully we can continue our discussion later on. Colleague, just to remind you that we still have like main events starting at 5:30 p.m. For dinner, and then we will continue to the main event. Pak Imran, again, thank you very much, Pak. Please, warm applause for Pak Imran. So I think we come to end of our program for this afternoon for this side event. Before I give the floor back to the MC, I would like to share several notes. Of course, colleague, thank you very much for your presence, for your active participation, questions, and also for all the panelists, the presenters, the organizing committees who work very hard, in making this event possible for us. Again, colleagues, investing in our health transformation system is not only save life, but also it enhance our health resilient system throughout our nation. So that's why I encourage you to consider those proposals. Again, we have almost 28 program proposals this afternoon that we are trying to increase almost 1.1 billion US dollars for this program. But of course, this is not only, we have a lot of programs that we can offer to you, colleagues and donors and partners. Please feel free to contact each of our team for those details. Again, I encourage you to visit our poster outside. So as we have finally come to the end of this program, let me convey again my gratitude to all to those who are participating in this event. I know we have like a couple hours for discussion, and then question and answer is a tiring day. But again, we still have like a main event for tonight. So on behalf of Ministry of Health and Government of Indonesia, I would like to convey my deepest appreciation, especially for partners and potential partners, for, again, as I mentioned earlier in my opening remarks, for walking with us in this journey. Thank you very much. I will give the floor back to the MC. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Once again, please give a round of applause for Bapak Harditya Suryawanto for moderating such insightful and comprehensive sessions. And ladies and gentlemen, may all the programs which we have discussed during the site event be fully implemented and of course evolve into concrete collaborations. And yes, ladies and gentlemen, we have come to the end of today's side event, or this afternoon side event. But please do stay with us in just a moment, because we will have the dinner as our main event and networking moments to know each and every one of us better. But in the meantime, we kindly invite you to please do leave this room as we prepare for tonight's main event or tonight's dinner. And so please don't forget to bring your belongings with you, and we will be here once again at 7:30 p.m. Once again, ladies and gentlemen, we kindly request you for please to leave the room, and please do bring your items with you, as we are to prepare for our main event tonight, which is the dinner at 7:30 p.m. latest, as we will begin tonight's dinner and of course main event. Once again, we thank you for your participation, and we look forward to seeing you and welcome you again at 7:30 p.m. tonight. Thank you very much. Ladies and gentlemen, we invite you to please enjoy the dinner that is served at the foyer area of the ballroom. And we invite you to please kindly leave the room as we prepare for tonight's main event. Once again, ladies and gentlemen, we invite you to enjoy the dinner that is served at the foyer area of the ballroom. And we kindly request for you to do please leave and bring your belongings with you, as we are to prepare for tonight's main event. And we hope to see you again at tonight's main event at 7:30 p.m. Thank you. Distinguished guests, ladies and gentlemen, welcome to the main event of the third Indonesia Health Partners Meeting 2025. Distinguished guests, ladies and gentlemen, tonight's opening performance presents a beautiful sequence of dances from 6 provinces all across Indonesia: Kalimantan, Batak, Aceh, Padang, Bali, and also Papua, woven together into one harmonious medley. This performance, ladies and gentlemen, reminds us of the strength of solidarity in diversity, especially as we stand together with our brothers and sisters affected by the recent disaster in Sumatra. Distinguished guests, ladies and gentlemen, please welcome Medley Nusantara.
Di balik sosok para atlet yang memperjuangkan kemenangan di arena pertandingan, tiap individu dari mereka lahir dari sebuah keberaneka-ragaman. Tanah kelahiran, kekayaan budaya, dan kisah perjuangan. Mengukir tubuh dan jiwa mereka yang membuat mereka bisa berdiri dengan gagah perkasa memperjuangkan mimpi-mimpinya. Dan malam ini, bersama-sama kita rayakan kekuatan keberagaman yang membentuk tanah air kita, Indonesia.
gentlemen, once again, please give a round of applause for Nusantara Medley. Indeed, what a magical and captivating performance to start our main event of tonight. Distinguished guests, ladies and gentlemen, my name is Sarah Wayne and I will be your master of ceremony for this tonight. And ladies and gentlemen, it is a great honor for me to be part of this wonderful event, the third Indonesia Health Partners Meeting 2025. Please give a round of applause for our main event of the night. Distinguished guests, ladies and gentlemen, the Indonesia Health Partners Meeting, or IHPM, is an annual forum organized by the Ministry of Health of the Republic of Indonesia in close collaboration with development partners. This forum serves as a platform to strengthen collaboration and also shared commitment in accelerating health transformation here in Indonesia. And the third Indonesia Health Partners Meeting 2025 in conjunction with the 61st National Health Day, carrying the theme Harmony for Indonesia Health Transformation Acceleration. And we are very honored to welcome our distinguished guests, ambassadors, leaders of development partners and ministries, and of course our colleagues, the health experts and professionals. Can I have a big round of applause for each and every one of you here? Thank you very much for attending our event. Distinguished guests, ladies and gentlemen, throughout the session this evening, there will be some sessions which will be delivered in Bahasa Indonesia. We have an interpretation device that you may use. Please feel free to do so if needed. Once again, ladies and gentlemen, there will be some sessions delivered in Bahasa Indonesia, so please do feel free to use our interpretation device or ask assistance from our team, and they will be more than happy to help you with. And next, ladies and gentlemen, we will reflect on our shared journey in transforming Indonesia's health system. We will be celebrating best practices and reaffirm ambitious goals to achieve our common vision, a healthier Indonesia. And now we are about to begin the session that we have all been waiting for this evening, a session where we will hear Indonesia's vision and strategy to achieve its health transformation goals. So without further ado, we are honored to have this session led by one of Indonesia's most respected journalists and editors-in-chief, Ibu Uni Lubis from IDN Times. Ladies and gentlemen, please welcome onto the stage, Ibu Uni Lubis.
Thank you, MC. And I would like to invite Minister of Health of Indonesia, Pak Budi Gunadi Sadikin. I promise this is not going to be a long event, a long session, but I would like to start it with welcoming and greeting distinguished guests, ladies and gentlemen, stakeholders of Indonesia's health sector. And we are supposed to have another panel, but not yet coming. I also see many attendees here, excellencies, ambassador, and representative from friendly countries, leaders of international institutions, and all invited guests at this event. As we all know that our thoughts are with our family, Indonesian family, experiencing the flash floods in 3 provinces, Aceh, North Sumatra, and West Sumatra. I believe that Minister of Health just came back yesterday from the visit with the President. And I would like to update actually from the dashboard of Minister of Health, which is you can follow, very updated. For 2 weeks now, the latest figures this afternoon show at least 974 deaths, more than 280 still missing, more than 5,000 injured, 140,000 houses damaged, 52 district cities affected out of 75 district and cities in 3 provinces, and more than 800,000 people evacuated across more than 1,000 locations. The shelter, several villages have been lost. 31 hospitals and 156 primary health centers, puskesmas, have been impacted. A small portion are operating on an emergency basis. 24 are severely damaged, all in Aceh. In my 35 years journalism career, this is the largest and the most devastating flood disaster I have witnessed. And I've been covered almost every disaster, included the tsunami in Aceh. I was one of the first journalists arrived right the day after tsunami. And 2 days ago, Governor Muzakir Manaf of Aceh, a former commander of the Free Aceh movement who spent his youth in guerrilla warfare in the forest before the peace agreement between GAM and the Indonesian government, stated, they died not because of the flood victims, but from starvation. Because many remain isolated due to the blocked roads and have not received sufficient food. As I mentioned earlier, it has been 2 weeks since November 26. On this phase 2, health issues typically emerge under such dire condition. We must not allow the death toll to rise due to delay health assistance. In normal times, primary health center, puskesmas, have increasingly become a mainstay, and the government, through the Ministry of Health, quite successfully, as a journalist, I have to say quite, not yet success. So there is no, it's already there, right? We are not there yet. Has carried out significant transformation in this sector. The resilience of puskesmas become even more critical during a crisis like this. We need collaboration from all parties, especially those gathered here with us tonight. So that's why I would like to ask the first question to the minister. What are the critical targets that need to be achieved during the 2025-2045 government period? I mean, we have the Indonesian Golden Vision, but I think probably in your time as a minister, which is hopefully until 2029, and also probably you can give a nuance from your visit to the field ground, experiencing the very, very devastating disaster.
So before we talk about the plan in the future, we talk about what's happening on the ground now. I was one of the first minister came to the disaster actually, because it was an accident. So I have to go to Sumatra Barat, Padang. One day before I went there, the flood happens. So I happened to be, I think, one or the first minister who were there. I remember that before my plane landed, it's already raining heavily. Land in Padang, Sumatra Barat, I have an event, that is the reason why I came to Sumatra Barat, not because of the flood, because the flood just happened the day before. And then after that, the governor asked me to go to the flood area. I'm so surprised because it's rising very fast in the middle of the city. And then it never stopped raining for a second. And I spent my time
it was 26,
in Padang.
27 of November, yeah? It was started 26.
Yeah.
So you arrived 27, yeah?
On that
Yeah.
date. So it never stopped a second until I left Padang 7 hours, 8 hours. So it's always raining. And the water is keep increasing. I want to go to one location and they said, "Pa, because you delay your visit by 15 minutes, like just now you delay by 5 minutes, the water level is already very high. So I have to move to another locations. So I came back. I didn't realize that the damage will be this big at that time. I know it's big, but I didn't realize it will be this big. So yesterday I came to Aceh with the president, and just to let you know, my job as a health minister, I have to make sure that the healthcare services for all the refugees, number one, and the people in these three provinces remain the same. So I told the team, we have a daily evening call, Zoom call with them. Simple objective, the healthcare services to the refugees and to all people remain the same. So the first job, the rest, the bridges, the food is not our responsibility because our hand will be very, very full. So the first objective is to make sure the 31 hospitals which are impacted up and running as quickly as possible. People said, why not Puskesmas, why hospital? Puskesmas is during normal time, we deal with the Puskesmas. During bad times, the critical goes to the hospital, we better get the hospital ready. And when I arrived, 15 hospitals are not operating. Now it's only two more.
Still not operating?
Two more are still not operating, but 3 of them are operating, but they don't have the logistic because there is no land access to 3 cities. Like, what is the name? Benar Meriah. Takengon in Aceh and Middle Aceh, and Gayo Lues. But Gayo Lues opened 2 days ago. And Benar Meriah, hopefully in the next 2 days. And then Takengon will be on the 17th of December. So the hospital, the problem is no electricity. How can you open a hospital without electricity? And we have 10 locations with no electricity. So we have to, a sling, like use a helicopter to carry the genset, full with gasoline, which is very dangerous. I think it will be very dangerous. And take it up and put it on the hospital. But they only stay for 3 days. Because after 3 days, they're running out of petroleum. And there is no way to bring the petroleum. So we have to bring the hospital again and bring the petroleum to this hospital. Once the electricity is up, we have problem with the water. Because we need water. And then that takes another 1 or 2 days for operating the hospital. When we have access to water, we turn on the light, we realize that the mud is this thick. Because now it's not raining anymore, so they're hardened. So we have to clean up all the hospitals. So it takes another 3 and 4 days. The last 2 hospitals now we are cleaning up. After we are cleaning up, then we understand that all the medical devices has been flooded. So when we start to turn it on, the anesthetic machines, because we want to operate the pregnant mothers, then it burned. So we need to send by today all the technicians from Siemens, Philips, GE to fly to Aceh, especially to check on those medical devices. If they are working, hopefully in the next 2 or 3 days, then we need to make sure the doctors and the nurses are coming. The problem with us now, the doctors and the nurses are also the victims. And they don't have houses. Some of them cannot eat. They are still taking care of their families. So that is another problem. So we have to export some doctors and nurses from other cities to coming in. So hopefully in the next 1 or 2 weeks, it will be settled. And then we will go to the 300 Puskesmas. Because still 44 are destroyed. And this Puskesmas is needed to take care of that 80 refugees locations. And then the normal populations.
1,000.
Posko pengungsian. Enggak, posko pengungsian.
Yeah,
it's 868. That's the latest number that I received. 868 locations for refugees, and then also the normal people.
Mostly in Aceh,
But this one, the severity level of the sickness is not as critical as the hospital. The hospital, my first job is emergency should be up. The operating room should be up because for pregnant mothers, so and accident and trauma, and then the hemodialysis. Already 5 or 6 hemodialysis patients that need to go to hemodialysis twice a week also already die because the machines are not working. Right?
Yeah.
So they die. So those are the priorities that we are going to do in the next 2 or 3 weeks.
And I would like to appreciate.
And we still have a lot of food problem. But to be honest, I have to raise my hand. That is somebody else.
That's the distribution.
That is
I
somebody
think
else.
the food is there from various parties, including the government, but the distribution is become a very
I forgot to tell
difficult.
you. There are the last yesterday meeting with the president, 135 bridges are down or lost or gone. And to build the bridges, it will take 12 months to 18 months, right? So the president asked the minister of public works. He said, 18 months. So, and different with minister of public work and 4-star general, is 4-star general will say, yes, we will do it. So then he changed the assignment to the 4-star general, the Maruli. Maruli is
The chief army.
the chief of army.
So they
no, you're
built
not
the
the chief
Bailey-
army, you're
Bailey
the chief
village.
of the bridges. You're the chief of
Bailey.
the bridges. So you have to build bridges. Can you do it in 3 months? He said,
Can do it
oh,
in
you have to
8
say,
days.
yes, sharp.
8 days. 8 days.
Yes, you can do it.
We have experience.
Yeah, he
in
has
tsunami.
experience to build Baileys, whatever
Baileys.
they call it. Then
Yeah.
we had problem with the Baileys. But 130 bridges. And some of them are very, very long. So I can imagine. That is the reason why we have food problems, because we only
Yeah.
can do dropping with helicopters. I think 40 helicopters are already there.
Yeah,
But
they-
if
they
you
work
talk about
24 hours.
800 refugee center,
Yeah.
it's still not.
24 hours.
it's not there.
The pilot actually is not easy to do the hover, right? To make sure that as close to the ground.
That is the past and the current. So let's talk about the future.
Yes.
2029. Do you want to be healthy, all of you? My question, why do you want to be healthy?
Because
Why
you
do you want to be healthy?
live longer and for the
Yes.
family.
Nobody want to live healthy and die tomorrow. No one, right? You want to be healthy because you want to live long. So the average life of Indonesia now is 72. The target 2029, we need to increase to 75. Simple. Why? Because to be healthy, you want to live long. I just came back from Japan Sunday. There are 100,000 centenarian in Japan. For you that doesn't understand the word, you can Google, or let me explain to you, centenarians is the people that have the age above 100. In Japan, it's 100,000. 0.08%. The highest in the world. 7 times the average of the world, 0.01%. So our target is to increase our average life expectancy from 72 to 75. Because why? Because that is the only reason why you spend money to stay healthy. But there is another indicator. Do you want to live long but cripple? Or do you want to live long with Alzheimer? Or do you want to live long like Stephen Hawking? No, right? So that is a second indicator. Average life expectancy, or ALE we call it, and we have another measurement called HALE. Healthy average life of expectancy. In Indonesia, the current healthy average life of expectancy is 60. So people like my age, that will be 62, average is not healthy anymore. Either they have tooth problems, or they have crimples, stroke, or they have physical problem, cannot walk. That is typical Indonesians. So we want to increase the healthy average life expectancy from 60 to 65. So those are the two targets. Why you spend money to pay your healthcare bill? Because you want to be healthy. Why you want to be healthy? You want to live long. You want to live long cripple, or you want to live long healthy? I want to live long healthy. Live long, the target is 75. Live healthy, the target is 65. So that is the target, Ibu. I mean, so that is what everything that I will do to achieve those two targets.
So, can you update us about, at least we are almost end of the year, what is actually the latest update on the health transformation that you are doing? Probably there is you can share the number and what will be the quick win for the next year?
So then the question is, how do you go there? How do you achieve the average life expectancy of, 75 and the healthy life expectancy of 65? The most important strategy is simple as, please stay healthy. So that is a simple strategy.
And how?
Don't get sick. Stay healthy and don't get sick. That is very simple, but it's very important because many people, many health ministers, many healthcare professionals, what they do is to cure sick people, not to keep people healthy. First, it's unfair because sick people in Indonesia only 20 million. Healthy people 260 million. So if you talk about equity, it's very unfair. You only take care to cure sick people, not to keep people healthy. You only take care 20 million of Indonesia, not 260 million of Indonesians. Second, it's much more expensive to cure sick people rather than to keep people healthy. And that is what the reality is. The Minister of Health, before, we spend 80% of my budget to cure sick people, not to keep people healthy. I don't blame the situations, but because most of us in the health ministry are doctors, doctors have been trained 20 years to cure sick people. Very few doctors are trained to keep people healthy because when they keep people healthy, they don't need the doctors. They're mostly like that. Right? But that is a simple strategy, how to keep people healthy. So that's why we do 6-pillar reform, how to keep Indonesian people healthy. And basically there are two things in health, they call it promotive and preventive. So you need to educate yourself. You have to understand the healthy lifestyle, like those Japanese that can live 100 years, is not to eat too much. You have to exercise also every day, and you have to sleep well. And you have to meditate, don't have so much stress. You have to change their lifestyle. So you have to educate your people that this is the way. And then of course you have to do prevention. Prevention is like immunization, screening. When your screening is yellow or red, then you have to take medicine or change your lifestyle. But I try to make it simple. Our strategy is to keep people healthy, not to be sick. And how to keep people healthy? First, lifestyle. We have to educate, we have to train. You have to see that Indonesian, like the Japanese, you see the difference between Indonesian and Japanese? I just came from Japan. I don't want to choose the wrong word. The body size is different. I'm not fat, but when I see my Japanese colleague, all of them are like him. Like this. The Indonesian is like this.
Shape.
The shape is like this. The Japanese are like, you see the Japanese. A typical Japanese man, Japanese woman is like this. You see the Japanese prime minister, this. So that is behavior. That is behavior. They eat fish. We eat gorengan. We eat gorengan. Okay, I stop here. Because I don't want to make another mistake.
And of course, you want to try to give example, right? You always try to be in prime condition because you are the marathon runner. Tepuk tangan dong ya. Not many health minister in the world is marathon runner and also a banker, yeah. But I was about to ask about the financing, the burden, the challenges. But I know you are a banker, and I follow you negotiate with several agencies during our time in World Health Assembly in Geneva, so should be no problem, right? So I don't have to ask to ask that question. Okay, this is the stakeholders in front of us. What kind of collaborative effort you expect, collaboration you expect in achieving your target as a Minister of Health?
So keep people healthy, we need a lot of, we need money. We need money.
Still.
I just
Still.
Yes, I just arrived from a meeting in Japan, where for the first time, formally, two heads of the World Organization, called one World Health Organizations, the president of World Health Organizations, and the president of World Bank, sit together with several health ministers and several finance ministers, talking about how can we finance the global health funding requirements with the new global health architecture. Because everybody complain, all the health ministers, except health minister of Indonesia, of course, they complain that there is less money from the overseas development assistance, the ODA money. The problem with health ministers, they are not good in numbers, usually. So I said, do you know, you are keep complaining in the last 6 months, there is no ODA money, but how much money is actually gone? Nobody can give me an answer. Until I have attending World Health Summit in Berlin, one organization called Donor Trackers show the numbers. It reduced by 40 billion this year and top at 60 billion next year. Reductions of overseas development assistance funding that goes to healthcare sector. So I'm a very practical person. If you lost 60 billion from overseas development assistance, then you have to look for replacement, right? Minimum 40 billion. You need to be efficient also. We don't believe that we are very efficient, but at least you have to look for 50 billion-ish replacement value. There is only one non-sovereign organization that can do such volume. Not even the Gates Foundation. Gates Foundation maybe 10, 15 can do. But there is one single organization that can do 50, 60 billion cash flow, outflow per year. The biggest bank in the world. The name is the World Bank. So that is the reason I came to the World Bank. I don't know whether somebody...
There is Patrick. I saw Patrick, right?
Patrick is there, you know.
We
I met with your
exchanged.
boss, President Ajay Banga. Fortunately, Ajay Banga is my friend for 30 years. I said to Ajay, you have been giving money for the country to develop bridges, toll roads, energy sector, you know, power plant, including coal power plant, you know, and then seaport, airport. Yeah, we do that. It's good for development of the people in the country. You know, what investment is better than building the infrastructure physical? Healthcare. Because it will ensure that the people will live and people will have productivity. Yeah, that's why I lent it to you, 4 billion US. Yes, but you mentioned to me that we are very proud of it because this is the biggest ever World Bank loan in this sector. That is very small amount of money. Can you see how much money that the World Bank give to power plant or to toll road or to bridges or to seaport or airport? Multi-billions US dollar. So that's why I managed to convince his boss, and then I realized it's very small. I should invest more. So that's a good thing about having somebody that understands finance and Minister of Health. And suddenly said, I will make sure I will allocate funding for 1.5 billion. Yeah, it must be 1.5 billion people out of 8 billion people in the world. So that is the reason, Bu, we need to get the funding right. But when we get the funding right, and World Bank now is coming in, so we have somebody that can disburse the money, the cash flow. The cash flow will be slightly different. Some of cash flow is for free, no money, no interest. This one is for a small interest. But I always tell also the countries, you cannot, you know, all of you are the father or the mother. Do you believe that you give the money to your children until they reach 50? That's not good, right? You only give the money until they graduate and then stop giving the money. Not because we don't love them, but if we keep giving the money, Dad, I want to buy a car, give him money. Dad, I want to buy a house, give him money. Dad, I want to remarry again, you give him money. That's not good. That's not good. It's not the way you educate your people how to live. So the developing country like Indonesia, we have to understand, we have to have a very clear financial pathway. In the next 15 years, we have to be independent. Now, Indonesia lives 6 billion budget. I have, outstanding maybe 5 to 6 billion loan for 5 years. So 1 billion is, so 25% of my funding coming from the banks. So when Ibu Sri Mulyani cut my budget, I'm not that shaky. Why? Because 25% is I got it from the banks. The rest of the ministry, 100% give to Sri Mulyani. They don't understand how to manage the funding risk. They put all their eggs in one basket, which is the Ministry of Finance. I know, I understand Ministry of Finance in Indonesia sometimes cannot be reliable. That's why I need to find another source. That is the reason I'm here. And what I shared with you is very important. Why? Because you know that I'm a banker. I will spend the money properly. And why I need the money? Because if we have the cash flow upfront, we can bring tomorrow's today. We can realize the dream from 10 years, then make it a reality in 2 years. And why you need to do it in health? Because it saves life. It's different with bridges. We can delay bridges, we can delay power plant, we can delay seaport. 2 years, 5 years, 10 years, it's okay. But if you delay health, then you are responsible of 1,000, 100,000 or millions of people's life.
Let's support the health transformation of Minister of Health because that will support Indonesian people future. So he is always passionate when talking about numbers, I mean, okay, that's end of our conversation. Thank you so much, Pak Budi, and congratulations for the third Indonesia Health Partners meeting. I think this 3 days, until tomorrow.
Somebody need to talk about the real numbers. We are talking about how passionate I am and why funding is important, but we still need berapa Pak? 40 million US if I'm not mistaken that we want to fill, and our target is berapa Pak Kunta? 19 million or whatever numbers. Pak Bona, you need to make sure that these are the program that we have done. And these are the money that he has been received, 9 million. 9 million has been allocated fully. We would like to fill in the multi-donor trust fund. And we have list of programs until 2029. McKinsey helped us design all the programs. And we already committed a certain funding volume from the government budget. There is a gap. If we can fill the gap quickly, then we can bring all the activities forward. Rather than, I give you an example, Pak Ibu, sorry. Like example, we want to vaccinate Indonesian women with HPV vaccine because this is number 2 killers in cancer, and it is unneeded death of Indonesian mothers, more than 20,000 deaths every year. Why? Because the vaccines are available. The problem is if we finish the vaccination in 5 years, then we let 20,000 Indonesian women die every year, right? So why don't we bring it forward and make it 1 year? Of course, when we bring it 1 year, we need a cash flow. So that is the reason why the required cash flow is to bring it forward. Because when we bring it forward, it can save 20,000, 30,000 Indonesian women's life. And I just do hope that they pray for me so I will go to heaven.
I hope the current Minister of Finance will support you because both of you coming from same city, same university, rivalry as the best student in Institute Teknologi Bandung. Hopefully. Thank you so much, Minister. And I give back to the MC. Thank you.
Thank you very much. Please give a round of applause once again to the Minister of Health of the Republic of Indonesia and of course our moderator, Ibu Uni Lubis. Thank you very much for the wonderful discussion and especially the insights and how to keep Indonesia healthy, especially today at the 3rd Indonesia Health Partners meeting, how we can collaborate and, of course, have a wonderful partnership to achieve that common goal. So once again, ladies and gentlemen, give a round of applause. Thank you for the wonderful discussion session.
Indonesia, a vast archipelago filled with challenges and hope. Across the nation, the health transformation is moving forward, not alone, but in harmony with our partners. With the support of partners, Indonesia strengthens primary care, enhances referral services, builds health resilience, improves financing systems, advances health human resources, and accelerates the use of health technology. The 6 pillars of health transformation stand as our foundation: primary health services, referral health services, health resilience, health financing, health human resources, health technology, all moving forward together. From eliminating tuberculosis to ending malaria in remote regions, from maternal and child health to reaching zero-dose children, from eye health services on distant islands to digitalizing health facilities. These are the true harmonies of transformation. To all partners working hand in hand with the government and the people of Indonesia. This is harmony for Indonesia Health Transformation Acceleration. To advance our transformation pillars, we cannot walk alone. We move forward together with our development partners. To all Ministry of Health partners, thank you for standing with the government and the people of Indonesia.
Distinguished guests, ladies and gentlemen, the journey to advance promotive and preventive efforts is never easy. And yet, we choose to keep moving forward. For our next speaker has given us the living example, continuing the fight through various international NGOs, and now is leading the transformation of primary health services in Indonesia. Ladies and gentlemen, let's give a big round of applause for Bapak Roy Himawan, the Director General of Budget Financing and Risk Management, Ministry of Health of the Republic of Indonesia.
Thank you and good night, Excellencies, Minister, and distinguished participants of this beneficial meeting. So I would like to invite all the participants to join us on our journey, as Pak Budi mentioned earlier, to transform our health system moving forward to promotive preventive. This is what we have now as a primary healthcare transformation. So I would like to invite all of you join us on several slides as follow. So if we go to the next slide, you will see that it is our passion to work to reach all the people.
the minister always asks us to reach all the people, not to mention those who live on the very remote area. So this is, if the slide may work, that we'll send to you about how the people being reached, including on our promotive preventive action through our free annual health checkup. So by having this program, we're able to touch more than 60 million of people on the not more than 10 months. So we provide them opportunity for those to live better by understanding their health status. So if this slide may work, then after we provide them the primary intervention for health checkup, we are providing them with a better operation mode of our community health center through the approach that we call integrated primary care services. This meant that all the components in community health center do as a one team together, provide action based on cluster. Not only by disease base, but we are looking people as their age needed. So by having them provide them services that according for their life age. So this is the slide to inform you that we have mentioned before that we want to reach all the puskesmas, we want to reach all the people, and to provide them better opportunity to live healthier through, as example, free annual health checkup. That now we already reach more than 60 million people have been tested across Indonesia. On the next slide, you will see that this is now moving forward. Pak Budi always mentioned to us, not only stop by checking, but you need to ensure there is follow-up after the result. So then we start to make digitalization of our primary healthcare. Supported by our partner, we are able now to provide digitally enabled district. So for those of district officers, primary health officers, they may understand what is the status of their residents in the working area. So we are working with partners to provide them digitally enabled dashboard, so that they will understand what is the result of the health checkup, what is the problem of the residents, and they can take action how to deliver the action. On the next slide, you will see the testimony of our primary healthcare officers. She said that this approach provides us better opportunity to understand the problem and to work closely as a team. And by connecting data, we're able to provide the real intervention that needed by community. This that we have from our colleague from Bogor that provide us testimony on the urgency of the model. On the next slide, it will be much more touchy. On the next slide is a testimony from our midwife worker that works in a primary healthcare center, that in the next slide, if possible, we will understand her testimony. Please go to the next slide for the testimony. Yeah. Is there any sound?
Pencatatan dilakukan secara manual atau berbasis kertas, sehingga dalam prosesnya memerlukan waktu dan juga biaya yang tidak sedikit, terutama dalam pengadaan format ataupun formulir. Nah, sekarang pencatatan sebagian besar sudah beralih ke sistem informasi digital, sehingga di sini prosesnya lebih cepat, lebih rapi, dan tentunya dapat menekan anggaran atau efisiensi anggaran di puskesmas.
Thank you. So that's testimony of our colleague from the primary healthcare center. And for the closing, I would like to invite all the donors, all the donors, do invest on our primary healthcare transformation. Thank you very much.
Once again, thank you very much, Bapak Roy Himawan. Distinguished guests, ladies and gentlemen, a hospital represents more than just infrastructure. It symbolizes hope for those seeking health and also care. And the Emirates Indonesia Cardiology Hospital in Solo is just one of the many achievements born from our collaboration. And tonight, we will hear more about these milestones from a well-known leader at the Ministry of Health. I would like to also inform you, ladies and gentlemen, that this session will be delivered in Bahasa Indonesia. Therefore, we invite you to please use your interpretation device if needed, and feel free to ask for assistance from our team if you need any assistance. Next, ladies and gentlemen, without further ado, please welcome onto the stage Bapak Azhar Jaya, the Director General of Advanced Health.
Good night, ladies and gentlemen, Pak Menteri. I will try to English not in Indonesia. I must quick because I have only 3 minutes to talk about our relationship with MDTF. First, I have a good connection with the ISDB because ISDB give a loan from the 2 projects. The first project is about the mother and child. They give us loan to build new building in 5 hospital in Jakarta, Darmais Hospital, Persahabatan Hospital, in Yogyakarta, Sarjito Hospital, in Makassar, Wahidin Hospital, and Bali Hospital. The hospital is in Bandung. I'm so sorry forget. In Bandung. This project is about mother and child, and the project has finished. We have a new building in the 5 hospital, and the building can increase our capacity to serve patient from mother and child, especially for the difficult case. And the second project is about cancer. Is loaned by HDB2. And the project is still going, and I hope in the next year we have a 5 building too in oncology or cancer. And the second project is very special from the World Bank. World Bank give loan for the build new hospital in the 3 provinces. The first province in the Papua, the second in the Maluku, and the third in the NTT. And the hospital has finished it, and they serve the people and can reduce our referral patient from the East Indonesia to the West Indonesia. Thank you very much from the World Bank. And the third project is very special, because the donation not come from MDTF or the government. They come from private hospital. The project is a donation from the Tokosukai, the private hospital in Japan. They give donation about 1 trillion rupees to build 22 floor building for the cardiologists in the Jantung Harapan Kita Hospital. And that is an example that we collaboration with the MDTF or the organization donor. For the next, Pak Menteri, for the next we hope the MDTF can help us to increase our capacity in the hospital to become a teaching hospital. We call it a hospital base. That is very important for us, because Indonesia is still need about 70,000 specialists. And our capacity to produce specialists is only about 2,000 or 3,000 specialists in years. That's why we need increase our capacity for the hospital for produce the specialists. And I heard, multi donors from ISDB or maybe IDB or AIIB, very interesting to funding this project. That is all. Thank you very much.
Once again, thank you, Bapak Azhar Jaya.
Indonesia, negara kepulauan dengan lebih dari 17.000 pulau, menghadapi tantangan besar dalam distribusi logistik kesehatan, terutama untuk menjangkau wilayah terpencil. Namun kini, teknologi membuka jalan bagi kemudahan dan efisiensi. Melalui kolaborasi Kementerian Kesehatan Republik Indonesia dan UNDP, lahirlah SMILE, Sistem Monitoring Inventory Logistik Elektronik. Aplikasi ini membantu menyeimbangkan stok, mencegah pemborosan obat, dan mempercepat pelaporan logistik dari gudang pusat hingga puskesmas di daerah. Kini SMILE hadir di 38 provinsi dan lebih dari 10.000 puskesmas di seluruh Indonesia. Untuk menilai dampaknya, dilakukan studi di 3 provinsi dengan karakteristik berbeda. Daerah Istimewa Yogyakarta, Sumba Barat Daya, dan Papua.
SMILE ini juga pasti akan sangat terpengaruh oleh hal-hal yang bersifat ekonomis tersebut. Program yang dilakukan, misalkan SMILE, SMILE yang dilakukan ini juga bisa berjalan dengan efektif, bisa berjalan dengan baik dan mendukung terlaksananya program dengan baik, seperti itu.
Mencakup 100 puskesmas yang merepresentasikan wilayah dengan sistem logistik bervariasi, dari yang sudah mapan hingga yang menghadapi tantangan geografis berat. Data dikumpulkan melalui pendekatan mixed methods, menggabungkan analisa kuantitatif dan kualitatif. Sumba Barat Daya, salah satu wilayah studi serta merupakan zona merah malaria. Kelangkaan obat anti malaria kerap terjadi karena jarak dan transportasi yang sulit.
SMILE ini sangat membantu kami dalam pelayanan di puskesmas, sehingga pencatatan pelaporan yang ada di puskesmas mudah kami kirim dengan segera.
Saat ini, melalui SMILE, petugas bisa memantau stok secara real-time dan mengajukan permintaan sebelum kekosongan terjadi. Di ujung timur Indonesia, Papua menghadapi tantangan yang hampir serupa. Banyak puskesmas hanya dapat dijangkau lewat pesawat kecil dan menelusuri sungai berjam-jam. Dengan SMILE, informasi stok kini terhubung hingga tingkat provinsi dan pusat. Keputusan bisa diambil lebih cepat, berbasis data, memastikan rantai pasok tetap berjalan, bahkan di wilayah paling terpencil.
Kalau menurut saya pakai aplikasi SMILE sangat mudah. Dengan begini mempermudah kita juga untuk membantu. Tinggal kita untuk buka di aplikasi, kita buat pesanan ke dinas, akhirnya dinas tahu kalau kita membutuhkan obat malaria, DHP dengan PK sekian.
Dengan dukungan teknologi dan kolaborasi lintas pihak, Indonesia melangkah menuju sistem logistik kesehatan yang tangguh, transparan, dan berkeadilan. Demi tercapainya akses kesehatan yang setara bagi semua.
And yes, ladies and gentlemen, what we have just saw right now, Smile Satu Sehat Logistics, shows how collaboration can make a real difference, saving millions of lives. And for this achievement, Smile Satu Sehat Logistics has been honored with the Excellence Award in Health Supply Management by the National Institute of Public Administration. And next, we will hear another wonderful story about the transformation of pharmaceutical and medical devices in Indonesia from an inspiring woman leader at the Ministry of Health. So without further ado, please welcome onto the stage Ibu Agusdini Banun Saptaningsi, the Director of Pharmaceutical Management and Services.
Yang terhormat pada Bapak Menteri Kesehatan dan Bapak Ibu Pejabat Eselon 1 dan Eselon 2. Distinguished guests, ladies and gentlemen, allow me to present a brief overview of the progress of the Satu Sehat Logistik Smile. Satu Sehat Logistik Smile, a transformative digital monitoring system to strengthen the health logistics management by providing convenience with broader and larger outputs. We have key achievements used in 10,200 primary health cares, 514 district health offices, and 38 provincial health offices and 200 labs. Linked to 56,000 posyandu private sites specifically for vaccine management and 6,000 temperature loggers for cold chain monitoring. And Smile Satu Sehat Logistik can reduce stockouts by 27% and overstocking by 31%. Support One Health through integrated rabies data system and simplified logistic management recording across HIV, TB, and malaria programs. The integrated Satu Sehat Logistik Smile system will be able to support real-time monitoring of health logistics supplies across all posyandu, puskesmas, and health facilities nationwide, minimizing the manual-based recording and reporting system, and providing automatic and accurate reports both in real time or periodic. And with this integration, health logistic control can be optimally managed through availability of real-time data on stock, request, order, allocation, receive, discard, disposal, and report. Next step, Smile for new vaccines, rabies, dengue, etc., health or lab supplies, and climate resilience health system. Number 2, reversal training for health staff, development of modules, e-learning, help desk optimization, systems integration, and Smile platform. Next. Alhamdulillah, we have the assessment of the Policy Quality Index. The Directorate of Pharmaceutical Management and Services received the award for outstanding achievement for the successful implementation of the Smile policy presented by National Institute of Public Administration, or LAN, and this recognition highlights SMILE's contribution to strengthening health supply availability and advancing public administration quality standards. Policy quality rating score is 93.94. Is the highest score for the Ministry of Health. Award for Outstanding Achievement 2025 Health Supplies Availability Control, or SMILE, on December 7 to 2025. Thank you for the nurse that has support us for SMILE. Thank you very much.
Thank you very much, Ibu Dini, for the inspiring presentation for us all. And now, distinguished colleagues and our dearest friends, our meeting this year comes at a time of sorrow as we remember the disaster affecting our friends, brothers, and sisters in Sumatra. Lives have been lost and many more are suffering. This evening, let us come together in harmony to strengthen our collaboration and turn empathy into action. Let us lead with empathy and take action to help our brothers and sisters recover from this tragedy. And tonight, let's stand in solidarity. Distinguished friends, let us unite in harmony to assist our family in Aceh, North Sumatra, West Sumatra. The Ministry of Health is dedicated to helping our families in Aceh, North Sumatra, West Sumatra, on their path to recovery. Let's turn the harmony and collaboration we celebrate tonight into real acts of support in any way we can.
Ale tuaku tangis dohani lau menghadapi nama sao ojo tutup pikiran nami maring songo lalilu raga roba rupilo nangakasain dihasianano ale Tuhan romaho mandulo bawa ahabanan nabi udah pahlawan songgo sita orang itu habiru waspa ale Tuhan orang bagi masmu sabu hormat akan dosa kami luas personal kami mendiori ngolu di portillo luas marhamu bau jalan buduk Tuhan Raja pesan dalam satu lelang tanah datang dua agang datang juo salam moko nandi kaki kiri berwarna baranda ini bang lalu lemarda. Kironya hujan lebih ngana di hulu di tengah malam datang galodo alam madarun maluluah lantang wanco nagari maluluah lantang kampung nagari Tadi mencari main kami marah hati memandang kurang tinggal Allah tu tolong hatikan Allah hadirua agar saudara datang antoran kami diranaminan hanya Tuhan ampun segala kesalahan Dia di hati kalau lagi lari malam malah depannya sakit di hari siang imano hati pendidikan asal sansam diuji bana kini sirana mina di hati kalau dilari malam nang malah pepane sakit di hari siang imano hati onde tindakan sangsa diuji bana kini sana mina.
Terima kasih.
Thank you for the heartfelt performance, and we offer this performance, distinguished guests, ladies and gentlemen, in solidarity with our brothers and sisters in Sumatra. As we reflect on the message that it carries, our thoughts, prayers, and deepest sympathy goes out to all the victims. May strength and healing be with all those affected by this tragedy. And next, distinguished guests, ladies and gentlemen, we will move on to our next session, where next we will hear the story about one of the most transformational program, the hospital-based university. And this exciting session will be led by one of the most powerful women leaders at the Ministry of Health of the Republic of Indonesia. And once again, we invite you, ladies and gentlemen, to use the interpretation device if needed. So without further ado, ladies and gentlemen, please join me in welcoming onto the stage to discuss the hospital-based university, the Director for the Health Workforce Provision, Ibu Ana Kurniati, along with Dr. Freddy, Dr. Desi, and Dr. Fitri. Please give a round of applause.
Selamat malam. Senang sekali kami berada di sini dan juga terima kasih kepada seluruh international partners yang sudah hadir. Malam ini kami akan menyampaikan salah satu program yang sangat transformatif untuk mengatasi kekurangan dokter spesialis di Indonesia. Tahun kemarin 2024, Kementerian Kesehatan telah membuka 6 sponsoring institution at 6 hospitals to open 6 study programs for neurologists, cardiologists, pediatrics, eye doctor, ophthalmologists, and also oncology radiation oncologist. And ada 3 dokter yang saat ini sedang menjadi residen di 3 rumah sakit. Yang pertama ada Dr. Fitri Florencia, kemudian Dr. Freddy Linardo, dan Dr. Desi Prinaswari. 3 dokter ini berasal dari Dr. Fitri berasal dari NTT dan Dr. Freddy dari Kalimantan Utara dan Dr. Desi berasal dari Sulawesi Selatan. Selamat malam para dokter.
Selamat malam Ibu, selamat malam Bapak Menkes.
Saya akan menyampaikan 2 pertanyaan untuk setiap dokter, dan 3 dokter ini adalah bukti nyata bahwa begitu program hospital base dibuka tahun lalu, kita langsung punya 109 residen, dan hari ini kami hadirkan 3 orang residen supaya Bapak Ibu sekalian bisa mengetahui seperti apa pengalaman mereka di hospital base Kementerian Kesehatan. Pertanyaan yang pertama akan saya sampaikan kepada Dr. Desi Frinansari Doki. Dr. Desi, bisa diceritakan bagaimana kondisi kedokteran anak di Kabupaten Tanah Toraja, tempat dokter berasal, dan coba diceritakan juga bagaimana ceritanya kemudian bisa menjadi residen RSPPU di Prodi Anak di RSAB Harapan Kita. Silakan dok.
Baik, terima kasih Ibu atas kesempatan yang diberikan kepada saya. Selamat malam Bapak Ibu sekalian. Saya akan menceritakan sedikit tentang bagaimana saya bisa menjadi dokter spesialis dan bergabung dalam RSPPU, PPDS RSPPU saat ini. Saya berasal dari Tanah Toraja, salah satu kabupaten di Sulawesi Selatan. Dari saya kecil, saya tinggal di desa, dan saya sebenarnya tidak pernah bermimpi bahwa saya akan berdiri di tempat ini, memberikan kesaksian bahwa saya bisa bersekolah melanjutkan sebagai dokter, bahkan sebagai dokter spesialis anak. Saya setelah menempuh pendidikan sebagai dokter, kemudian saya melanjutkan sebagai Nusantara Sehat waktu itu di pedalaman Kalimantan, dan dari situ saya begitu banyak menangani kasus yang sebenarnya bisa tertangani dengan cepat, tapi keterbatasan dari para dokter yang ditempatkan di daerah itu sangat berkurang. Jadi sangat susah untuk akses mendapatkan pelayanan kesehatan, dan sangat terbatas untuk bisa mengakses pelayanan tersebut. Inilah yang menjadi dasar dan semangat saya untuk bisa melanjutkan ke PPDS. Nah, pada saat RSPPU terbuka, ini sangat inovasi dari pemerintah yang sangat membuka kesempatan bagi kami yang tinggal di daerah, terlebih khususnya di daerah yang sangat terpencil, yang untuk mengakses informasi sendiri, untuk mengakses pendidikan di spesialis itu sebenarnya itu adalah sebuah cita-cita yang mungkin dipikir akan sulit, tapi dengan terbukanya PPDS RSPPU ini membuka peluang bagi kami semua yang tinggal di daerah untuk dapat mengakses pendidikan pelayanan kesehatan, dan pada akhirnya nanti kami akan kembali mengabdikan diri ke daerah. Dan semoga kami berharap bahwa pelayanan dari keberlanjutan dari PPDS RSPPU ini akan terus berlanjut sehingga makin banyak dokter-dokter di daerah yang bisa melanjutkan pendidikan spesialisnya dan dapat mengabdikan diri kembali ke daerah. Sekian dan terima kasih.
Ya, terima kasih dokter. Selanjutnya Dokter Fitri. Dokter Fitri berasal dari NTT dan saya ingin tahu seperti apa kondisi kesehatan masyarakat yang ada di NTT dan kenapa yang menyebabkan Dokter Desi kemudian memilih Dokter Fitri memilih menjadi seorang dokter dan memilihnya di RSPPU. Silakan Dok.
Terima kasih atas kesempatannya Ibu. Hadirin sekalian, perkenalkan nama saya Dr. Fitri Florentina. Saya berasal dari kabupaten kecil, kabupaten kepulauan di Nusa Tenggara Timur, yaitu Kabupaten Flores Timur. Kalau Bapak Ibu tahu Labuan Bajo, itu adalah Flores paling barat dan saya berasal dari Flores bagian timur. Kota yang tidak dikenali banyak orang, namun adalah sebuah kota wisata yang religius. Di Kabupaten Flores Timur itu kami sangat kekurangan dokter. Jujur dokter-dokter kami itu berasal dari Nusantara Sehat, Tuksus atau PTT. Adapun beberapa PNS yang berasal dari luar namun tidak bertahan lama. Setelah beberapa tahun sebelum masa baktinya selesai, itu memutuskan untuk kembali ke daerahnya. Itu dari segi dokter umum, apalagi dokter spesialis. Kami memiliki dokter spesialis itu terutama bantuan dari beasiswa Kementerian Kesehatan untuk menjalani masa pengabdiannya, namun setelah beberapa tahun masa pengabdian itu terpenuhi, dokter-dokter spesialis tersebut memilih untuk kembali ke daerah asalnya. Nah, untuk dokter spesialis saraf sendiri, Bapak Ibu sekalian, di Kabupaten Flores Timur itu tidak pernah ada satupun dokter spesialis saraf.
Wow, luar biasa ini, ada
Betul,
satu
Ibu.
lagi yang akan punya ya.
Iya, puji. Sehingga penata laksanaan kasus stroke di Kabupaten Flores Timur itu sangat tidak baik. Masyarakat kami adalah sebagian besar petani dan nelayan. Sehingga apabila penanganan stroke itu tidak dijalani dengan baik, akan berakhir pada luaran atau outcome yaitu disability. Dan masyarakat yang sangat berharap kepada kemampuan untuk pertanian dan pelayanan tersebut jika mengalami disabilitas maka akan melumpuhkan dari segi ekonomi sebuah keluarga ataupun lebih dari sebuah keluarga. Oleh karena itu, saya memutuskan dan memang sudah lama bercita-cita untuk menjadi dokter spesialis neurologi. Cuman seperti yang kita tahu bersama, dokter di daerah terpencil Ibu memiliki keterbatasan yang berbeda dibanding dokter di daerah perkotaan. Satu, akses terhadap perkembangan atau updating ilmu itu sangat terbatas. Dan dari segi transportasi maupun akomodasi dari Nusa Tenggara Timur ke daerah Jawa atau Bali di mana center pendidikan itu berasal cukup mahal. Dan kemudian kedua, sarana prasarana kami di daerah perifer itu sangat terbatas sehingga kemampuan skill kami pun jujur memang terbatas. Sehingga ketika saya mendengar pertama kali dicanangkan mengenai hospital base, itu saya sangat berharap agar dapat melanjutkan jenjang pendidikan dokter spesialis melalui hospital base ini karena saya melihat hospital base ini dapat memahami apa yang kami rasakan di daerah DTPK dan visi misi dari Bapak Menkes luar biasa. Dan saya boleh mengatakan bahwa semua yang Bapak Menkes katakan itu benar adanya. Dan harapan saya Pak, PPDS RSPPU ini bisa tetap berlangsung karena saya yakin anime dokter-dokter di daerah terpencil itu sangat tinggi. Dan saya yakin jumlah pendaftarannya pasti akan meningkat setiap batch-nya. Jadi demikian harapan saya, semoga itu terwujud. Terima kasih.
Tepuk tangan untuk Dokter Fitri, luar biasa. Akan menjadi pertama kalinya dokter spesialis saraf di sana ya.
Amin, amin.
Ya. Kemudian yang berikutnya Dokter Freddy, yang paling ganteng di tengah. Dokter Freddy saat ini studi di Rumah Sakit Darmais ya. Bisa diceritakan Dok, seperti apa kondisi kesehatan masyarakat di Tarakan, Kalimantan Utara dan apa sih sebetulnya yang mendorong dokter mendaftar sebagai residen RSPPU di Kanker Darmais? Silakan Dok.
Selamat malam Ibu, selamat malam para hadirin sekalian. Perkenalkan, nama saya Freddy Linardo, saya asal dari Tarakan, Kalimantan Utara. Untuk pengalaman selama saya bekerja, terutama yang paling kita mengalami kesulitan ya di tempat saya bekerja di rumah sakit provinsi, jadi memang tipe B saat ini. Dari pengalaman saya 7 tahun bekerja itu, kasus yang paling sulit atau yang paling menantang buat kita hadapi itu adalah kasus kanker. Pasien-pasien kanker di tempat kita itu rata-rata tidak bisa kita rujuk. Tidak bisa dirujuknya bukan karena tidak ada biaya untuk membiayai pengobatannya. Masalahnya adalah biaya akomodasinya yang terlalu tinggi. Di mana perawatan kanker sendiri butuh waktu yang sangat lama. Untuk radioterapi, untuk kemoterapi bisa berbulan-bulan, bahkan bisa sampai tahun hitungannya. Yang paling mahal adalah biaya akomodasi yang harus dikeluarkan oleh pasien dan keluarga. Itulah yang akhirnya menggerakkan saya kenapa saya memilih onkologi radiasi. Karena bagi saya solusinya bukan merujuk pasien keluar, tapi kita mendatangkan SDM-nya, mendatangkan dokter spesialisnya dan juga alat-alatnya untuk hadir di daerah sehingga semua masyarakat kita bisa merasakan apa itu namanya pelayanan kesehatan yang adil gitu. Nah, kenapa saya memilih program RSPPU? Karena bagi saya visi yang diajukan oleh pendidikan RSPPU ini sejalan dengan apa yang saya mau. Yang saya mau adalah kami di daerah itu bisa mendapatkan hak untuk pendidikan yang sama atau bahkan bisa diprioritaskan, terutama bagi kami yang anak asli daerah. Saya dari kecil di Tarakan, jadi saya berharap saya bisa kembali ke Tarakan, membawa ilmu yang saya pelajari, dan juga Kemenkes mampu untuk mendukung saya dalam pendidikan, serta pengadaan alat nantinya, karena saya juga tidak bisa bekerja kalau nggak ada alatnya. Jadi ke depannya saya berharap program ini bisa terus berjalan, dan secara paralel juga dari Kementerian Kesehatan mampu untuk mengadakan peralatan yang sesuai dengan kompetensi dan kebutuhan masyarakat di daerah.
Ya, kita berikan aplaus kepada 3 dokter spesial. Bapak Ibu yang kami hormati, ini adalah bukti nyata bahwa program hospital base yang diinisiasi oleh Bapak Menteri Kesehatan membawa angin segar terutama kepada dokter-dokter yang ada di daerah. Dan tadi sudah kita dengarkan bahwa mereka juga menaruh perhatian yang sangat tinggi untuk memastikan masyarakat yang ada di daerahnya nantinya akan memiliki dokter spesialis sesuai dengan kebutuhan. Kita doakan 3 dokter yang saat ini sedang menempuh pendidikan residensi di 3 rumah sakit, semuanya akan menyelesaikan pendidikan tepat pada waktunya, supaya cita-citanya untuk kembali mengabdi ke daerah asalnya dapat segera terwujud. Dan mudah-mudahan sesuai dengan harapan teman-teman para residen, kita akan terus meningkatkan pendidikan hospital base kita, menambah lagi RSPPU dan juga program-program studi yang saat ini sangat dibutuhkan oleh masyarakat. Demikian dari kami, terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Once again, thank you, Ibu Ana, Dr. Freddy, Dr. Desi, and Dr. Fitri. Please give another round of applause. Thank you for the sharing session and of course for giving the proof of how the hospital-based university program is a real game changer here in Indonesia. And implementing such innovation, ladies and gentlemen, is never easy, but our focus remains on its lasting impact, especially for the whole Indonesia to feel. Because as we all know, our president, Bapak Prabowo Subianto, has made it very clear that Indonesia must never ever lack doctors. So tonight, we invite all development partners to stand with us in this mission. And next, we move on to our next session, ladies and gentlemen, where we will move to another breakthrough in the health biotechnology transformation, the precision medicine of Indonesia. So let's welcome on to the stage the Director of Center for Biomedical and Health Genomics, Ministry of Health, Ibu Indri Roslamiati.
distinguished audience, donors, and partners, ladies and gentlemen. So thank you for your trust and partnerships. So I will share some updates on the impact of the program that you've been invested for the past 2 years. So let me start with one key reality. So precision medicine cannot be precise if the evidence does not come from the reference population where it is meant to serve. So most reference data come from European populations, while Indonesia, which is in Southeast Asia, we remains underrepresented. And when the data isn't representative, the consequences are real. So diagnosis take longer, and treatment are less tailored, and inequity can quietly grow. So therefore, in 2022, the Ministry of Health launched the Biomedical Genome Science Initiative. So this is not a one-time project, but this is an inclusive national genomic ecosystem. We are building the biobanks, the national biobanks. We're also building the capacity to do the sequencings and secure data governance. And also we make sure that the research is translated into the healthcare services. So genomics can move from research into real services. So we are focused on the priority that matters to communities: tuberculosis, metabolic disease such as the diabetes, the genetic disorders for the rare diseases, and also maternal and neonatal health, cancer, cardiovascular, stroke, mental health, healthy aging, and the general populations, because we need to be sure that the populations is represented. So with your support, now we can build the Indonesian reference data and make a precision medicine more accessible and equitable. So precision medicine is not a privilege, but something everyone can access. And because of the partnership in this room, we have moved from vision to a measurable national impact, because our minister likes numbers, so I will show you the numbers. So we have recruited almost 20,000 participants in our national biobank and sequenced almost 15,000 individuals and generated more than 7,000 pharmacogenomics reports. Why pharmacogenomics report is important? Because it can show you what medicine is suitable for you, what's best for you, what dose you have to take, and what medicine that you need to be avoided. And the last one, how to reduce the side effect. And also, we're strengthening the TB surveillance by expanding our sequencing laboratory network. So in parallel, we are not only collecting the data, we are not only collecting the samples, but we're also accelerating research by providing the data access through our portal. It's back a secure, trusted research environment that can be utilized by the ecosystem. So most importantly, this impact is reaching people. We are now cover more than 36 provinces and is open for all Indonesians. So we have implemented 7 genetic services in public hospitals, including cancers, diabetes, and we return over 2,000 NGS results to support clinical care and initiating the Indonesian Gene Bank to sustain this work long term. Our interim results show that nearly 1 in 2 Indonesians may need the pharmacogenomics guided treatment adjustments. So the pharmacogenomics instead, it supports the safer prescribing and provides an evidence to the doctors to give the best medicine to the patients, and also to give the evidence to the policymaker to procure the drugs that better suits the Indonesian populations. With your support, we can scale this nationwide. So your support has not been just funding. It just turned an idea into a system that serves people. So our purpose is simple. So we ensure every Indonesian can benefit from this modern science. They say it's complicated and expensive, but we have the capability, we have the capacity. So your support will turn into life-changing impact and a lasting legacy. So this will shorten diagnostic journey So the patient, they don't need to get through like the more than 10 tests and what is exact diagnosis that they have. We will also would like to improve the treatment decisions and deliver fairer health cares for our diverse populations. So Indonesia, we are not starting from zero, but we are building a real momentum with a growing network and clear results. So because behind every data set is a person waiting for an answers. Your support can turn uncertainty into a diagnosis, and a diagnosis into a right treatment, and hope into better health for millions of Indonesians. So thank you for your partnership for the last 2 years. Together, let's make this impact last. Looking forward for our continued collaborations. Thank you.
Thank you very much, Ibu Indri. And yes, let's go together to advance the precision medicine ecosystem here in Indonesia. And now, distinguished guests, ladies and gentlemen, and our beloved colleagues, your presence tonight means so much to us, as does the collaboration that we have built together and the future that we envision together. And now it is time for us to give you an award which hopefully will last forever. So therefore, for our awarding session, we kindly invite the representatives whose organizations' names are called to please come forward and please come up onto the stage to receive the award. And we will begin for our first category. The country representatives. The government of Australia. Please give a round of applause. And next, the government of the United States of America. United Arab Emirates. The government of Canada. The government of South Korea. The government of Japan. The government of the United Kingdom. The government of Saudi Arabia. The government of the People's Republic of China. The government of Sweden. The government of Iran. The government of Germany. The government of Turkey. The government of the Netherlands. The government of Singapore, and the government of Kuwait. Once again, ladies and gentlemen, please give a round of applause. And next, ladies and gentlemen, here are the country representatives whose collaboration is significant to our efforts. And next, we'd like to invite onto the stage, with respect to present the award to the Minister of Health of the Republic of Indonesia, His Excellency, Minister Budi Gunadi Sadikin. Please give a round of applause, ladies and gentlemen, to Minister Budi Gunadi Sadikin. We invite you to please kindly present the award to all country representatives whose partnership and collaboration have strengthened and accelerated health transformation in Indonesia. And next, Your Excellency, Minister, please take a position on stage to take a picture of the appreciation presented to all country representatives at the 3rd Indonesia Health Partners Meeting 2025. Once again, please give a round of applause, ladies and gentlemen. And I will help with the countdown. 3, 2, 1. Once again, 3, 2, 1. Thank you very much, Your Excellency. And to all representatives, you may return to your seat, but please exit through stage left. Ma'am, please exit through stage left. And we'd like to invite you to please collect your cases for the award. Once again, thank you, and we extend our greatest gratitude for the token of appreciation for the collaboration. And next, we will continue to our next category, which is the development partners and donors. We'd like to invite onto the stage to receive the token of appreciation from the World Bank. Please give a round of applause. Asian Development Bank, Islamic Development Bank, Asian Infrastructure Investment Bank, Global Fund, Gates Foundation, Toko Shukai Medical Group, Global Alliance for Vaccines and Immunization, World Health Organization, United Nations International Children's Emergency Fund, UNICEF, U.S. Centers for Disease Control and Prevention, United Nations Population Fund, United Nations Development Program, Japan International Cooperation Agency, Korea International Cooperation Agency, Lemming Fund. And next, ladies and gentlemen, please give a round of applause for. Next, we'd like to also invite to present the token of appreciation, Bapak Kutawibawa Dasanugraha. We kindly request for your presence on stage to please present the token of appreciation. And once again, we'd like to remind to all receivers of the token of appreciation to please exit or leave the stage from stage left to collect the cases for the token of appreciation. And next, please, we invite you to please take a picture on stage, Bapak Kutawibawa Dasanugraha.